One respected seniors and colleagues. Today I will be presenting with this journal of cancer and mortality rates across 43 registries in India. Journal, journal. ठीक. Sources Java Open Journal. Design is cross-sectional analysis, which was performed for the data from 2015 to 2019. The scope was 43 population-based cancer registries in India. Objectives of the study was to assess regional patterns in cancer incidence and mortality across India, estimate future cancer burden for 2024, and identify leading cancer types according to sex and geography, that is, various geographical regions of India. Evaluate disease using age-adjusted incidence rates and average annual percentage. Come to methodology. This report presents campaigns and mortality from 43 PBCR across India, which 33 are operated under National Center for Disease Informatics and Research. 9 are managed by Tata Memorial Center, Mumbai, and 1 is managed under Tamil Nadu Cancer Research Program, together consisting the NCRP. These PBCRs cover varying periods between 2015 to 2019, representing approximately 18% of India's population. Trend analysis was conducted for 23 populations from January 1st, 2002 to December 31st, 2019 to set the trends of how the disease is progressing. All neoplasms characterized by behavior code 3 according to the International Classification of Disease for Oncology, 3rd edition, and International Statistical Classification of Disease, that is ICD, and related health problems, 10th revision, were classified as reportable and subsequently recorded in the cancer registry. The Institutional Ethics Committee for National Center for Disease Informatics and Research approved the study, but consent was waived because it was an anonymized anonymized registry data. There was no direct handling of any patients. The study complied with the guidelines of strengthening of reporting of observational studies in epidemiology, that is STRO, for reporting observational study findings. This is the ICD-10 codes for all the malignant diseases. So it ranges from C00 to C97. Data quality indices were computed for each PBCR to assess the reliability of the data. Microscopic verification was done for 75%. Death certificate only verification was less than 10%. Other and unspecified sites of cancer were less than 10%. Data errors were flagged and sent back to the registries for clarification and cross-checked with the data source and corrected accordingly. And data quality was maintained according to the standards of International Association of Cancer Registries and International Agency for Research on Cancer. Incidence of cancer cases in India for 2024 was estimated using trends in cancer incidence rate and projected propagation. They analyzed trends from 2010 to 2019, state or region specific PVCR, to estimate cancer incidence rate by anatomical site and sex. For anatomical sites where the annual percent change was statistically significant, cancer incidence rates were estimated to 2024. For sites where APC was not statistically significant, the incidence rates from 2015 to 2019 were assumed to remain constant until 2024. Data on the population at risk by state and sex were obtained from Census of India. The estimated incidence rates for 2024 were then applied to respective projected population figures for each state and for entire country. Mortality estimates for India were modeled as a function of cancer incidence estimates and mortality to incidence ratios, stratified by anatomical site and sex based on the Mumbai PVCR. They took Mumbai PVCR as a central point and modeled the study around it. Coming to statistical analysis, They analyzed cancer incidence and mortality using data from all PBCRs. 7,08,223 cases and 2,06,457 deaths across varying periods between 2015 and 2019 were used for this analysis. Cancer statistics are cancer statistics are presented as a number of incident cases, risk-group incidence rate, and age-adjusted incidence rate per 1 lakh population using Indian standard population and world standard population. Here they use both Indian standard population and world standard population for like world standard population they have used for historical trend setting and Indian standard population they have used for accurately demarcating regions of interest. Similarly, the number of mortality cases, crude mortality rate, age-adjusted mortality rate per 1 lakh population, and mortalities to incidence ratio were derived, while the WSP allows for international and historical comparisons. The ISP was used as part of sensitivity analysis to assess the association of Indian population age structure with incidence estimates. To evaluate the lifetime risk of developing cancer, cumulative risk was calculated for ages 0 to 74 years. Coming to results, this is for all cancer cases for all sites, incidence rates per 1 lakh population, and cumulative risk by sex for all the cancer registries ranging from the years 2015 to 2019 in India. Here, in case of Madhya Pradesh, we only have Bhopal. So we have crude incidence rate of 98.2 and age adjusted incidence rate of 91.7 and cumulative risk of cancer is 12.3%. Uh, Cumulative risk is we have total cases in case of this for Bhopal. Numbers कहाँ से हैं? No, this is like urban population, how many, rural population, how many? So how many? We cannot see anything. But how many? They have not bothered to make it in a font size that people can read. आप पढ़ पा रहे हो ना? तो आप पढ़ के बोल दो. For Bhopal, number of cases were 4,638. 4,000. But over how many years? 2015 to 2019. You are 5 साल में केवल 4,000 कैंसर केसेस थे. For this registry for Bhopal only. That is possible. आपने Bhopal की कितनी होती है आपकी? पता नहीं है. हेडिंग क्या है इसकी सबसे ऊपर? For all cancer cases, incidence rates per 1 lakh. 2011 census population is and census population for males and is for females. What percentage है क्या है? पर 1 lakh population. Per 1 lakh population. आपके पे ना पर 1 lakh. सही. Yes, and for 1 lakh for this for the over the period of 5 years, there were how many cases per 1 lakh population? In case of males, it was 4,638. In case of females, it was 4,304. और उसके पहले की दो क्या लाइनें लिखी हैं अर्बन और रूरल का पूरा पढ़ा हम कुछ नहीं पढ़ पा रहे इसके वजह से. Ma'am, this is for urban population means like this is number for the doctor we can read. और तो 100 is for urban और रूरल के लिए 0. पढ़ते जाओ आगे इसमें क्या लिखा है. For in case of males, crude incidence ratio was 98.2. Age-adjusted incidence rate was 91.7. Cumulative risk of cancer, aged 0 to 74 years, was 12.3. In case of females, total number of cases was 4,304. Crude incidence rate per 1 lakh was 97.3. Age-adjusted incidence rate was 89.2, and cumulative risk of cancer. लेमन लैंग्वेज में क्या समझ आ रहा है, क्या आपने क्या समझाओगे? जैसे आपने बोल दिया कि ये क्रूड इंसिडेंस रेशियो इसका क्या मतलब? Per 1 lakh population of at risk, there will be at 97 people who will have an incidence of cancer. Yes, sir.
One day, this good incident around the 4,000 or 1 lakh cases.
No, 4,638 males and 4,304 females. So total is around 9,000.
See out now, rate है 2,000 पर 1 lakh cases.
This is only for Bhopal. एक मिनट, he has given what those number indicates. आपको क्वेश्चन समझ में आया? मतलब कि मतलब अगर टोटल इंसिडेंस 90 पर 1 लाख है तो आपका क्यूमुलेटिव 9,000 कैसे आ गया? तो फिर अभी की क्या आंसर है? नंबर इतना हम पढ़ पा रहे हैं ना, आपने ऊपर क्या लिखा है? 2011 census for 2011. This was census population percentage. Yes, sir. Yes, ma'am. किस चीज का percentage है? Of the total number of data sets that was taken, they are divided into urban and rural. तो ये percentage में numerator क्या है, denominator क्या है? Numerator is the data set that taking, and denominator is the total amount of. Don't talk rubbish. समझ नहीं आ रहा, numerator क्या है? What is data set? This is urban and rural. Numerator here is urban population in the data set, and then there is rural population. They have differentiated into two. Total urban male population. ठीक है, denominator for this. अभी हम numerator बात कर रहे हैं, तो क्या है numerator? Ma'am, for this column, the urban column, it is the number of patients who have come from urban area. Number of patients. ठीक है, और denominator क्या है? Denominator is the total number of patients. तो आप बोल रहे हो कि भोपाल की रजिस्ट्री में 100% मेल को कैंसर हो गया? No, this one is not differentiated into male and female. This is total population, male and female. No, no. 100% का मतलब है जो डेटा सेट ये लोग लिए है तो इसमें से 100% अर्बन पॉपुलेशन आया है. There was no percentage of rural population for भोपाल. तो मतलब ये कि टोटल कैंसर पेशेंट्स नहीं आए, टोटल कैंसर पेशेंट फ्रॉम अर्बन पॉपुलेशन अपॉन टोटल पेशेंट्स. आर यू श्योर कि ये पेशेंट है? population based population patient नहीं population. तो आप बोल रहे हो कि भोपाल डिस्ट्रिक्ट में 100% अर्बन पॉपुलेशन है. अब उसमें से फिर आपने क्या लिखा है? क्यूमुलेट फर्स्ट हो गया अर्बन रूरल, तीसरी हेडिंग क्या है? नंबर ऑफ केसेस इन मेल्स 4,000. हाँ, ये टोटल केसेस है. टोटल केसेस 4 साल में मेल्स में केवल 4,000 हुए. Now see, you have to, what I'm answering, you answer specific. Yes, ma'am.
तो आप बोल रहे हो कि 4 मेल पॉपुलेशन में केवल 4,000 पेशेंट केसेस हुए हैं,
4,638
तो आपकी टेबल में ऊपर पर 1 लाख क्यों लिखा हुआ है?
पर 1 लाख ही तो सारा मैम ये लोग डिटरमाइन करे पर 1 लाख ऑफ पॉपुलेशन टोटल नंबर ऑफ केसेस।
टोटल 4,000 हुआ, आप बोलोगे 4,000 पर 1 लाख पॉपुलेशन हुआ
Yes, ma'am.
है ना? तो दैट इज आई एम सेइंग लिसन टू माय क्वेश्चन प्रॉपर्ली। नाउ यू आर सेइंग कि 4,000 प्लस पेशेंट पर 1 लाख हुए
Per one
हैं
lakh.
टोटल 5 ईयर्स में।
Yes, ma'am. For males.
फिर उसके नेक्स्ट हेडिंग क्या है?
फिर इसका नेक्स्ट हेडिंग है crude incidence ratio per 1 lakh population, which is 98.2 in males. This is in males. This
क्रूड
section
इंसिडेंस
ratio
इसका
rate uh, number of new cases by total population into 1 lakh.
टोटल मेल पॉपुलेशन, मेल या टोटल?
Male. This is for male only. This section
फिर नंबर कितना निकला इसका?
98.2
आप बोलो 98। लेमन लैंग्वेज में समझाओ, व्हाट डू वी मतलब अंडरस्टैंड फ्रॉम दिस?
per 1 lakh population in males. There will be 98.2 males who will have an incidence of cancer. That is total number of cases. Incidence new. This is new cases.
What is the difference between 4,000 and 91? लेमन लैंग्वेज आपने ये बोला कि पर 1 लाख में से पर 1 लाख मेल्स में से 4,000 को कैंसर।
Yes, ma'am. That is total number of
आई अंडरस्टूड। अब ये क्रूड इंसिडेंस रेट को आप लेमन लैंग्वेज में बताओ।
This is for a specific point of time per year. Incidence rate is calculated in that formula. It is for one specific instant of time. It is calculated.
100 मान लेते हैं, राउंड ऑफ करके, तो 5 साल में 500 होगा, टोटल 4,000 कैसे हो गए?
ये पॉपुलेशन बेस्ड रजिस्ट्री के डाटा है। दिस मस्ट बी द होल पॉपुलेशन। भोपाल पॉपुलेशन बेस्ड रजिस्ट्री का एरिया उन्हें डिफाइन किया हो में से ये 4,000 पर ईयर जब केस आया, पर इंसिडेंस रेट ऑल ओवर इंडिया is 100.4 per 100 population. Crude incidence rate
Yes.
is 100.4 per 100 population. तो 4,000 पर 1 लाख तो हो ही नहीं सकता है। तो ये अगर भोपाल का आप देख रहे हैं तो भोपाल की जो टोटल पॉपुलेशन, और भोपाल की पॉपुलेशन अपने यहाँ मध्य प्रदेश में केवल भोपाल में पॉपुलेशन बेस्ड रजिस्ट्री है और नहीं है। तो भोपाल की जो टोटल पॉपुलेशन होती उसमें इतने केसेज निकाले कि कैंसर, ऐसा मुझे प्रतीत हो रहा है। ऐसा पड़ेगा
5 से 5 years का टोटल 5 years का प्लस 4 years 8 times of population, तो इसी 5 साल में अगर 500 तो इंसिडेंस पॉपुलेशन
इंसिडेंस ना ऐसे क्रॉस सेक्शनल नहीं होता। क्रॉस सेक्शनल इज प्रेवलेंस, इंसिडेंस इज न्यू रेट्स ओवर अ पीरियड ऑफ टाइम। तो it can हमने जून में सर्वे कर दिया, जून में हमें जितने भी केसेस मिले हमने उसको इंसिडेंस में डाल दिया। तो ऐसा नहीं होगा ना, इंसिडेंस इज ऑलवेज ओवर अ पीरियड ऑफ टाइम। अगर आपने जून में सर्वे कर लिया, आपको जितने पेशेंट मिले आपने उसको ले लिया, तो प्रेवलेंस है। टोटल नंबर ऑफ पेशेंट लिविंग विद कैंसर इज प्रेवलेंस। नंबर ऑफ इंसिडेंट मतलब केस न्यू केसेस डायग्नोज विल बी ओवर अ पीरियड ऑफ टाइम, इट इज नेवर ओवर वन डे।
In 1 year. Yes, sir.
और भोपाल की 100.8 पता है। population के लिए 4,000 नंबर आया, तो जितना रजिस्ट्री में पॉपुलेशन कवर की होगी उसका नंबर ऑफ जितने केसेस हैं उस पर्टिकुलर ड्यूरेशन में 4 साल
for males.
है।
Next paragraph.
Then there is age adjusted incidence rate. For
कोई दिखाई नहीं दे रहा, ये registered incidence rate आ गया।
using ISP 95% confidence interval. For that in Bhopal, in case of males, that is 91.7, and the range is from 89.1 to 94.4. Next, then there is cumulative risk of cancer, aged 0 years to 74 years, that is 12.3% in case of males.
अगेन आप इसको लेमन लैंग्वेज में कैसे समझाओगे? क्यूमुलेटिव आपको अवेयरनेस सेशन में जो है आपने बोला क्यूमुलेटिव रिस्क ऑफ कैंसर इज 12%। तो किसी ने पूछा व्हाट इट मींस।
Cumulative risk of cancer is we first calculate the multiple factors which are causing that event, and then we calculate the probability of that event happening in a specific point of time due to those multi factors.
इस स्टडी में कौन से मल्टी फैक्टर स्टडी की?
They have studied tobacco usage, obesity.
टोबैको यूसेज पर अपने मन से ही लगा रहे।
No, ma'am. They had written that tobacco usage, obesity. They have taken that as factors.
Cumulative risk of figure that the cumulative risk of cancer in India is 1 in 9. Risk. The 1 in 9 person in our country may suffer from cancer. कोई फिगर चल रहा है आजकल का ऐसे हमारा कार्य करता है कहता है risk of cancer।
आपने मटेरियल एंड मेथड में बताया नहीं कि टोबैको क्या क्या पढ़ा है, तो दोबारा जाना मटेरियल एंड मेथड पर। इस स्लाइड का क्या मतलब है?
Data quality indices means the data that they got from all the registries. They calculated the reliability and the quality of the data. That is, they use two variables. One is microscopic verification, that is, if there was biopsy was positive or not, and the next was for mortality data, death certificate only was the verification.
तुम्हारा क्या होगा?
Um,
या मैं देखता हूँ कि ये टोटल डेटा अगर 100% हमने पेशेंट लिए थे उसमें इतने परसेंटेज की डायग्नोसिस ऐसी थी, ऐसा है क्या? क्योंकि लास्ट टाइम आपने हमें ये लाइन बोली थी कि 75% का माइक्रोस्कोपिक वेरिफिकेशन था।
मतलब of
यू आर अंडरस्टैंडिंग माय क्वेश्चन?
yes, ma'am. Like only in case of 75% of the data there was microscopic verification, and in case of less than 10% of the data there was death certificate verification also.
No, it is to check the data which we are getting from the registries to check the data quality. So in the 75%, we have taken two standards. The microscopic verification was checking as a 75%. We have seen that the data we got from the registries was 75% correctly.
नहीं, ये इंडाइसेस है, इन्होंने थ्रेशोल्ड सेट किया है कि अगर 75% माइक्रोस्कोपिक डायग्नोसिस होगी तो मतलब आपका डेटा अच्छा है, अगर 75% से कम होगी तो इसका मतलब खराब डेटा। जो आप बोलते हो ना कि मतलब 100% क्वेश्चन है डेटा क्वालिटी इंडाइसेस। हाँ, तो जब जैसे आप टोटल अपने आईसीएमआर की रजिस्ट्री रखते हो, आप अगर सबकी माइक्रोस्कोपिक डायग्नोसिस नहीं मिल रही है, तो इनको भी नहीं मिली, तो 100% नहीं मिल सकती, लेकिन जब तक 75% में है तब तक इट इज ओके, योर डेटा क्वालिटी इज गुड। अगर आपका डेथ मोर्टालिटी सर्टिफिकेट है, तो अगर वो नंबर लेस देन 10% है तो ठीक है, लेकिन अगर डेथ प्रमाण आपको 15% में, दैट इज प्रूफ ऑफ डिजीज, देन इट इज नॉट गुड। समझ
That certificate वाला मतलब main cause of cancer should be there ना for that
जैसे फॉर
mortality
एग्जाम्पल किसी
cancer.
इंसान को सीए लंग था, वो मर गया, है ना, उसकी टिश्यू डायग्नोसिस नहीं हो पाई, तो आप उसकी कैसे प्रूफ करोगे? आप डेथ सर्टिफिकेट पर अगर सस्पेक्टेड सीए लंग लिखा होगा तो आप उसको रजिस्ट्री में इंक्लूड कर दोगे।
No, the thing मतलब जो मेरा question था, the question was this कि वो जब at the time of death it should be in the center where cancer can be detected or the data can
Not
be taken there.
necessarily,
No, other
because
center.
population based cancer registry is not from a cancer center, इट इज फ्रॉम पेरिफेरी। तो आप डेटा कलेक्ट करते हो, जो सर बोल रहे थे, शमशान घाट से, पैथोलॉजी लैब से, रेडियोलॉजी लैब से, जनरल हॉस्पिटल से,
जो डाटा इकट्ठा करो,
वो डेटा कैंसर हॉस्पिटल से इकट्ठा नहीं हो रहा है, आपके हॉस्पिटल में तो हॉस्पिटल बेस्ड कैंसर रजिस्ट्री। अब मेरा समझा मतलब पॉइंट इसमें यह है कि हम भी जैसे अपना डेटा क्वालिटी करते हैं, वी नॉट गेट माइक्रोस्कोपिक डायग्नोसिस इन 100%, बट इवन इफ यू आर गेटिंग इन 75% इट इज ओके।
एनाटॉमिकल साइट का भी कहीं वेरिएशन हुआ है।
हाँ मतलब unspecified sites of cancer should be less than 10% of the in the data.
अगर उससे ज्यादा है तो फिर वो आपका डेटा क्वालिटी गुड नहीं है।
इससे पहले उसमें कोई ट्यूमर हो गया, आपको आइडेंटिफाई स्पेसिफिक कर, एब्डोमेन में आपको साइट नहीं पता तो अनस्पेसिफिक साइट करते हैं। तो बहुत सारे जो C6 है अनस्पेसिफिक साइट के लिए है, इस तरह की कोडिंग।
कैंसर केसेस
Incidence of cancer cases for in India for 2024 was estimated using trends in cancer incidence rate and projected population. They studied it from 2001 to 2019, the trends of cancer in India, region specific, and then they use the data to extrapolate it to show if like what is the expected disease incidence for 2024.
इसमें आपने कोई और पॉइंट्स भी ट्रेंड स्टैटिस्टिकली सिग्निफिकेंट नॉट सिग्निफिकेंट?
Yes, ma'am. In this, that if uh,
देखो आपने पढ़ा था, बताओ ना क्या करना।
um, they calculated the cumulative risk of that disease in that specific site, and if they saw that it is more than 15%, then they took it and extrapolated it to 2024. If it was less, then they thought that the
कहाँ होता है?
15%.
का ये बहुत ही डाइवर्स रेशियो आया है। साउथ ईस्ट हमारा भोपाल से 11-12 नेक्स्ट से 2022 है। तो पूरा इस रीजंस में वो डिफरेंट जो ट्रेंड आया वो डिफरेंट ट्रेंड आया।
For different diseases also the trend is very different for in case of different regions.
मिजोरम में तो
15%
15% नहीं actually नहीं मैम, एक्चुअली स्टैटिस्टिकली अगर सिग्निफिकेंट है तो ही वो लोग कैरी फॉरवर्ड कर रहे हैं। आई रिगार्डिंग द देखना पड़ेगा, but for if it was statistically significant, then they carry forwarded it to 2024. Yes, ma'am.
If what was statistic? What?
If the annual percentage change was statistically significant, then
अभी आप इसके पहले सब बोल रहे थे क्यूमुलेटिव इंसिडेंट्स, क्यूमुलेटिव इंसिडेंट्स और स्टैटिस्टिकली सिग्निफिकेंट। आप वर्ड्स को इतना लाइटली क्यों ले रहे हो? हर किसी का अपना मतलब है ना। तो ये कैसे आप कैलकुलेट करोगे एनुअल परसेंटेज पे? आप हमें भी कंफ्यूज कर रहे हो, क्योंकि आपने मुझे पढ़ा नहीं आर्टिकल, and it was such an important article for us.
It is very Most that word can come with incident like significant advance. It is population based data. Whatever is coming to that as
कहीं आर्टिकल में मेंशन है कि किस चीज को उन्होंने स्टैटिस्टिकली सिग्निफिकेंट बोला है,
एनुअल परसेंटेज चेंज कोई
कट ऑफ होगा ना उसका कुछ। किस कैसे बताया उन्होंने कि स्टैटिस्टिकली सिग्निफिकेंट है कि नहीं?
they have used p value less than 0.05.
0.05। तो
Yes, ma'am.
नेक्स्ट पे आना, इस लाइन का मतलब बताना।
They used mortality and incidence of cancer from all the PBCRs, and they had found that there were total of 7,08,223 cases and 2,06,457 deaths for that time period, that is 2015 2019. And and they used Indian standard population and world standard population.
वो जो आपकी टेबल है उसमें क्रूड इंसिडेंस रेट इंडियन स्टैंडर्ड पॉपुलेशन के हिसाब से वर्ल्ड स्टैंडर्ड पॉपुलेशन।
According to Indian standard population.
नहीं, सेकंड एक्सप्लेन करिए ना।
So and ma'am, they also number of mortality cases, crude mortality cases, age-adjusted mortality cases. They calculated per 1 lakh population, and they also expressed in mortalities to incidence ratio. And then they said that why they use WSP as well as ISP. They explained it.
मतलब इसमें लास्ट में लिखा है, आपको इससे हिंट मिल जाएगी। To evaluate the lifetime risk of developing cancer, cumulative risk was calculated. आपसे जो उस टेबल में पूछ रहे थे cumulative risk है, इसका
Yes, ma'am.
age specify करा हुआ है इसमें।
Yes, ma'am.
Cumulative risk।
From 0 to 74 years.
जैसे फॉर एग्जाम्पल जब आप बोलते हो कि 15 साल तक कितने कैंसर हो सकते हैं, कम होता है कैंसर का इंसिडेंस, ये 50 साल तक में बढ़ जाएगा, 75% में और बढ़ जाएगा। तो जैसे एज बढ़ती जा रही है, डिफरेंट टाइप ऑफ कैंसर कम इनटू प्ले, तो फिर वो पूरी लाइफ टाइम की क्यूमुलेटिव रिस्क है उसकी।
Yes, ma'am.
आगे बढ़ो। तो आपने वो भोपाल का बता दिया, अब इसमें और कौन से दो स्टेट का भी एक्सप्लेन करो जिससे आप कंपेयर करना चाहते हो।
Northeast से ma'am Nagaland I would like to compare. It's next right now.
उसमें दिल्ली का तो बताओ, और दिल्ली other than भोपाल।
In case of Delhi, in that also, as per 2011 census, the population was 100% urban population and 0% was rural population. Males, there were 34,303 cases, total number of cases and per 1 lakh population, crude incidence rate was 116.5 in case of males. Age adjusted incidence rate in case of males using Indian standard population in Delhi was 117.5, and the range was from 116.2 to 118.8.
But do you see any alarming difference between Bhopal and Delhi?
Like there is a lot of difference.
There is a difference of more than 8 times again. 34,000 लिखा है।
More than 8 times.
4,000 or 34,000?
More than 8 times.
How will you explain this? आपको सोचना पड़ेगा ना कि एक जगह 4,000 पर लाख हो रहा है, जगह 32,000 पर लाख हो रहा है।
Reason for this discrepancy is due to lack of awareness in this region.
मोस्ट लाइकली तो भोपाल का डेटा कलेक्शन अच्छा नहीं होगा, इसलिए पॉपुलेशन भी वहाँ की डेली ज्यादा है। लेकिन वो तो पर वन
Per 1 lakh.
रजिस्ट्री कम हो गई
नहीं पर बन लेती ये incidence है ना तो पर बन
Per 1 lakh.
और जो नंबर ऑफ केसेस जो बताए हैं, they cannot be per 1 lakh.
total number
के केसेस आए पर 1 lakh तो हो ही नहीं सकता है। 4,000 या 34,000 पर 1 lakh कैसे हो जाएगा? ये तो टोटल पॉपुलेशन के जो केस, देखिए पॉपुलेशन बेस्ड कैंसर रजिस्ट्री है, तो दे आर रजिस्टरिंग द केस ऑफ होल पॉपुलेशन, दे आर कंपेयरिंग विद द पॉपुलेशन। तो जितनी पॉपुलेशन है हमारी और कितने केसेस दिल्ली एनसीआर में, दिल्ली का या दिल्ली एनसीआर का जो रजिस्टर्ड किए गए होंगे, उसके बेसिस पर उन्होंने ये डाटा निकाला। ये लगता है, आई एम नॉट श्योर, कि दिल्ली का फिगर इसलिए भी ज़्यादा आ सकता है कि इन दिल्ली पेशेंट फ्रॉम रेस्ट ऑफ द कंट्री दे आर आल्सो गोइंग फॉर द ट्रीटमेंट, दे आर रजिस्टर्ड इन द डिफरेंट हॉस्पिटल्स ऑफ द दिल्ली, है ना। आप अगर टाटा मेमोरियल का निकालो तो ना बॉम्बे का निकालो और ज़्यादा निकलेगा, क्योंकि पूरे इंडिया से केसेस बॉम्बे जाते हैं। ऐसे ही दिल्ली का ये जो डाटा है, दैट इज कलेक्टेड फ्रॉम ऑल द हॉस्पिटल्स इन द दिल्ली, पॉपुलेशन बेस्ड है, ये सारे हॉस्पिटल्स का कलेक्ट किया हुआ है। तो जो नंबर ऑफ द पेशेंट इन डिफरेंट हॉस्पिटल, डेफिनेटली दे आर गोइंग टू हायर देन भोपाल। भोपाल में तो जाएंगे नहीं, जो कंट्री के बेसिस पर पहुंचते हैं, दैट इज वाई नंबर इज हाई इन द दिल्ली, और इसमें पॉपुलेशन बेस्ड है।
आप सही बोल रहे हो, क्योंकि जो टेबल की हेडिंग है वो यही है। फर्स्ट थिंग इज कैंसर केसेस फॉर ऑल साइट्स।
Yes.
So this 34,300 is not per 1 lakh, it is total base. और फिर उसके बाद CIR पर 1 लाख है 116 और एज एडजस्टेड है 117।
मेडिकल का 15 से 17 में इसका
15 से 17 मतलब 2015 से 2017 डेटा कलेक्ट हुआ है, तब भी ज्यादा हो गए। भोपाल में लंबा था ज्यादा था। बॉम्बे पर भी
जो नंबर देंगे यहाँ पे मेडिकल कॉलेज की कॉलेज नहीं पहुंचते, वहाँ पे जो डेथ होती है कैंसर की, तो वहाँ पे अगर जो अनुभव तो अपने क्षेत्र में ज्यादा अन्य क्षेत्र में ज्यादा होती होंगी, जैसे वगैरह रिमोट एरिया उसमें एडेट्स जाती मतलब पता करते होंगे कोई मारे गया वैद्य से इलाज कराया कुछ किया।
वो भी नहीं हो सकता। पॉपुलेशन देयर वेरी फ्यू पॉपुलेशन बेस्ड कैंसर रजिस्ट्रीज।
मध्य प्रदेश में जैसे केवल भोपाल में, उसका ये प्रॉब्लम स्लाइड उसके लिए जो डाटा कलेक्ट किया जाता है डेथ का, भोपाल गैस कांड के बाद भोपाल डी इसीलिए गई थी। आई वॉज ट्राइंग फॉर लॉन्ग टाइम टू गेट पॉपुलेशन ऑन डिस्कस की नंबर ऑफ, बहुत कोशिश की लेकिन नहीं मिल पाई। हाँ, कहना चाहते हो अभी दे रहे हैं, पहले वो इस्तेमाल बंद करता था भोपाल को, उनने गैस कांड के बाद जब काम गैस का हुआ तो ये लगा कि केसेस बढ़ेंगी जनता में, तो देन देखे पॉपुलेशन जिससे ये जो जैसे ऐसा बोल रहे हैं कि मर जाते हैं, दैट इज वाई इन आवर कंट्री वी आर नॉट हैविंग द करेक्ट डाटा ऑफ इंसिडेंस ऑफ द कैंसर केसेस एंड मॉर्टेलिटी, बिकॉज रिपोर्टिंग इज नॉट प्रॉपर। रूरल एरिया में मर गए मालूम नहीं पड़ा, लेकिन इसलिए अब गवर्नमेंट ने कंपलसरी कर दिया बर्थ सर्टिफिकेट एंड डेथ सर्टिफिकेट। ये इसीलिए किया है कि अपन डेथ सर्टिफिकेट से ये मालूम कर सकें कि भाई डेथ हो रही है किस बीमारी से, उसमें कैंसर का भी डाटा निकल एंड दैट इज वाई दिस डाटा इज कलेक्टेड फ्रॉम दी म्युनिसिपल कॉर्पोरेशन द बेसिस ऑफ डेथ सर्टिफिकेट। और उस शमशान में भी डेथ होती है, वहाँ से भी अगर रजिस्टर है तो उससे कोशिश की जाती है कि वहाँ से कलेक्ट किया जाए।
किस कौन सी पॉपुलेशन बता रहे हो आप हमें?
Ma'am, now I'm going to show like the highest number and the lowest number in this study. Highest number was seen in Aizawl district of Mizoram. Here urban population was 78.6% and rural population was 21.4%. Number of cases males total was 2,253. Crude incidence rate per 1 lakh in males was 202. Age adjusted incidence rate in males was 198.4 Range was from 190.1 to 206.7. Cumulative risk of cancer in males was 26.1. Total number of cases in females were 2,124. Crude incidence rate in females per 1 lakh population was 181.9. Age adjusted incidence rate was 172.5 and ranged from 165 to 179.9. Cumulative risk of cancer in females aged 0 to 74 years were 22.1%. This is the highest value.
इसमें हम देखेंगे कि हाईएस्ट टू डेज but number of cases is less.
Yes, sir. Yes, sir.
Because
Population is less, sir.
that is why sufficient population की वजह से इधर आ रहा है.
And the least was in Osmanab and Beed in Maharashtra. In their case, urban population was 18.7%, rural population was 81.3%. Total number of cases male were 4,570. Crude incidence rate in 1 lakh for male were 37.4. Age adjusted incidence rate was 30.4 and ranged from 29.5 to 31.3. Cumulative risk of cancer was only 4% in case of males. In case of females, total number of cases were 5,433. Crude incidence rate was 48.9. Age adjusted incidence rate was 36.3 and ranged from 35.3 to 37.3. And cumulative risk of cancer in females aged 0 to 74 were 5 only. This was the least value for all the populations.
कौन सा जगह exactly कहाँ पे?
Maharashtra में
नहीं, महाराष्ट्र में
Beed and
महाराष्ट्र में जो
Osmanab.
दो population base है.
Yes, ma'am.
ये वार्षिक है.
Varshi rural area. They Varshi also had a similar cumulative risk of cancer in case of Varshi. This is also the other regions. It was the table continued.
तो तमिलनाडु की क्या बताया?
Tamil Nadu, Chennai, the urban population was 100%, rural population was 0%. Total number of cases male were 12,630. Crude incidence rate per 1 lakh male population were 131.2. Age adjusted incidence rate in case of males was 99.6. Ranged from 97.8 to 101.4.
स्कूली टेबल में सबसे ज्यादा कौन सी जगह है?
It's in Aizawl from Mizoram.
वो तो डेट है सबसे ज्यादा, मतलब CIR
Everything is highest.
कितने केस होते हैं केसेस?
Total cases was not high because the population is less. Number of cases was Delhi, 34,000. Highest was Delhi, ma'am.
लास्ट जो आप स्किप कर रहे थे ना स्लाइड, उसके सारे टोटल केसेस पढ़ दो. मैं देख के पढ़ ना टोटल केसेस.
In case of Visakhapatnam and Andhra Pradesh, data was taken only from 2017 to 2018. Urban population was
केवल टोटल केस.
2,104. In Bangalore, there was 21,321. Malabar, Kerala was 12,941. Kannur, Kerala was 9,387. Kasargod was 3,469. Kollam was 11,919. Thiruvananthapuram was 14,966. Pathamnitha was 1,408. Alappuzha was 2,360. Yes, Tamil Nadu was 88,665. In Chennai, it was 12,630. सबसे ज़्यादा in तमिलनाडु state.
तो भोपाल बोल रहे थे ना तो बच्चे सब हम जाके पब्लिक में बोलते थे कि सबसे ज्यादा केस भोपाल के हैं। आपने पढ़ा?
दिल्ली.
हाँ दिल्ली, सॉरी, अल्लाह के बोलते थे दिल्ली के हैं, लेकिन सबसे ज्यादा तमिलनाडु के हैं, ट्वाइस से भी ज्यादा।
इस स्लाइड से जैसे आपने देखा, we raised this question many times on the ICMR platform, but previously these registry were still right. जैसे केरला में आपको मिले 6 पॉपुलेशन बेस हो हमने काफी किया। There was a discrimination between south and north. बिहार में एक होगी, पूरे मध्य प्रदेश में एक है, यूपी में भी मुश्किल से एक कर दी। But in south there is many population bases. केरला में 6 है। Previously there was lot of funds were given to the south.
तो डॉक्टर साहब ये ICMR PDCR का है, ये डेटा किसने दिया है? ICMR ने कलेक्ट किया है?
No, they
ये डेटा आपने बताया था प्रेजेंट कर रहे हो, आपकी वेरी फर्स्ट स्लाइड थी कि किसने कलेक्ट किया है।
एक ही साइड से हमारा है तो डाटा में तीन होता है।
ICMR नहीं, इसमें नेशनल कैंसर रजिस्ट्री का तो
नेशनल कैंसर रजिस्ट्री करके तो कुछ नहीं है। जाओ अपनी फर्स्ट स्लाइड। ये जो डॉक्टर
पैरेलल कॉम्पोनेंट नेटवर्क क्या ज्यादा ही होता है, ये सेंटर इसका
ये है। So this is not ICMR. दोबारा बोलो, 33 are operated under
National Center for Disease Informatics and Research.
9 are
9 by Tata Memorial Center, TM Mumbai, and 1 is by Tamil Nadu Cancer Registry Program.
अलग से रजिस्ट्री तमिलनाडु में कर दिए, फिर इंडिपेंडेंट ऑफ ICMR।
Now, coming to the comparison of all cancer sites, age-adjusted incidence rates of all population-based cancer registries from 2015 to 2019. They have divided into males and females. In case of males, Isol was the highest. In females also, Isol had the highest age-adjusted incidence rates. Least was in Usmawad and Bid in both in males, and in females it was Dima. Dima. Nagaland.
नागालैंड का देखा नहीं था ना डेटा, हमने बर्शी बीट को ही मिनिमम मान लिया था।
Yes, ma'am.
देखने की जरूरत है।
Yes, ma'am.
दिखाओ। बीट का 37 लिखा है ना,
Yes, ma'am.
और ये इस जगह का कितना लिखा है?
Nagaland का है 77.0 in case of males and 9.8 in case of females.
तो नीचे वाला इसका 1 है ना, 37 ग्रीन वाला ही तो है।
Green वाला is Usmawad and Bid.
हाँ, तो 37 मेल का हो गया
हाँ
और
मैम,
फीमेल का कितना?
5.0.
तो कम है ना उससे,
कम है.
नागालैंड से कम है ना।
हाँ मैम.
तो आपकी टेबल में आपने नागालैंड को नीचे क्यों डाला?
No, they have differentiated in males and females. So females के क्षेत्र में नागालैंड का सबसे लीस्ट आया था.
इसमें कितना
बीट का है 5.0 and in case of Nagaland it is 9.8. Nagaland को.
रीड होना चाहिए ना आपके ग्राफ में सबसे नीचे।
No, this is cumulative risk of cancer. That was age-adjusted incidence ratio. Age-adjusted incidence rate.
इसमें एक फीमेल
Females का है.
फीमेल्स में नागालैंड का कितना है और बीट का कितना है?
Beat का है 36.3 and in case of Nagaland it is 76.2. Still more.
क्या है लगता है आपको
इसमें
क्या खटक रहा है?
मतलब इसमें जो दिखा रहे हैं उसके हिसाब से डेटा के साथ इनकंसिस्टेंसी. Comparison of all cancer sites, age adjusted incidence ratio of all population based cancer registries 2015-2019.
कहीं भी हो पॉइंट भी
दीमापुर
देख कौन सी जगह हो सकता है हम गले गले पे का देख आसान हाँ
नागालैंड में नहीं दी
आसाम देखो ना अपनी टेबल में यू हैव रेड दिस टेबल ना
इसमें
so you should be able to tell us where it is in the table.
yes ma'am, VMI is in Assam.
तो क्या है नंबर पर
For females, age adjusted incidence rate is 22.1. That is less than BEAD.
बीट की कितनी थी
36.3. Yes ma'am.
और इसमें दिल्ली का और भोपाल का ये भी दिखा दो कहाँ पे दिया स्टैंडिंग
Bhopal is in the middle. For males, it is around the middle, this region. And in females also,
एक मिनट
Delhi is here. For males and females both, it is showing the same trend. In case of lung cancer, Bhopal is around the middle. Highest is seen in Srinagar and lowest was seen in Muzaffarpur.
टोटल केसेस है
This is age-adjusted incidence rates in specific cancers.
श्रीनगर में लंग सबसे
Yes ma'am, श्रीनगर में सबसे ज़्यादा है. उसके बाद है आइजोल. Delhi is here. Smoking, ma'am, बहुत smoking. As well as use of coal. As well as ma'am, use of coal to keep themselves warm. उसके लिए भी ma'am use करते हैं.
नहीं कैंसर वाला ये लंग कैंसर की बात है लंग कैंसर स्मोकिंग नहीं कर सकते प्राइमरी कैंसर है
In case of oral cancer in females, highest is seen in East Khasi Hills. Bhopal stands fourth, and least is Srinagar. In case of males, highest is in Ahmedabad urban area. Second highest is Bhopal, and least is in Kashmir. In case of oral cancer. In case of stomach cancer, highest is seen in Papumtare, least is seen in Beed and Uzamabad, and Bhopal is pretty low. अरुणाचल प्रदेश में मैम ड्यू टू diet because they have a lot of spicy food and they also consume a lot of red meat. Yes. In case of males, highest is for stomach cancer is Aizawl, and least is Sangrur, and Bhopal stands pretty low in the list. In case of prostate cancer, highest is Srinagar, least is Karimganj. Bhopal is around middle of the list. वो लोग नहीं किए, वो लोग सिर्फ स्पेसिफिक कुछ डिजीजेस का वो लोग बनाया है इसमें.
ऑलरेडी लंग कैंसर इन फीमेल
नहीं मैम. Average annual percentage change and trends in age adjusted incidence rate from 2002 to 2019 for selected sites of cancer, they showed the trends. In case of males, oral cancer, Bhopal shows increase. Stomach cancer, they did not show Bhopal because they have shown selected. This table is showing, this is the baseline, and they are showing either there is trends of increase or decrease. So in case of Bhopal, for the time period of 2022 to 2019, they have shown increase in the average annual percentage change. Tables, they are showing only specific diseases in specific regions only. They are not showing it for all the regions and all the diseases.
मतलब जैसे हमने भोपाल का नंबर शायद 4.7 दिख रहा है ना?
Yes ma'am, this is 4.7.
तो ये 4.7 कैसे रहा होगा कि 2002 से 2019 में 4.7%
7% increase.
और डिक्रीज हो गया है नॉर्थ ईस्ट में.
Yes ma'am.
ठीक है. तो स्टमक का कहाँ इंक्रीज हो रहा है?
स्टमक का सबसे ज़्यादा इंक्रीज हुआ है कामरूप में 5.6%, एंड सबसे ज़्यादा डिक्रीज हुआ है आइजॉल में, मतलब पहले से. लंग कैंसर में सबसे ज़्यादा इंक्रीज हुआ है कामरूप में.
इसमें जीरो क्या रिप्रेजेंट है?
जीरो इज द परसेंटेज, लाइक इंक्रीज डिक्रीज का बेसलाइन है वो, मतलब
नॉट एवरीथिंग इज टचिंग जीरो ना.
नो मैम. नो चेंज.
नो चेंज फिर लंग में है. ठीक है.
लंग कैंसर में मैम हाईएस्ट इंक्रीज इज इन कामरूप and highest decrease is in Aurangabad, and no change as per you said. It's in Nagpur. For prostate, highest increase is in Thiruvananthapuram. Highest decrease is in Nagpur. Bhopal stands third from below. It is, they have shown it as stable.
तीन कलर के डॉट का लेबल क्या एक्सप्लेन किया?
Green is decrease, blue is stable, and red is increase.
तो जैसे कुछ पे इधर उधर फॉर्म कर रही है
Yes ma'am.
तो उसको वो स्टेबल
स्टेबल मान रहे, मतलब अप टू 1% का वो मतलब यहाँ के 1 तक वो स्टेबल लेवल पर मान.
मुझे माइनस 4 के बियॉन्ड कलर
They have done it from 1. Anything above 1 they have changed it to red.
दो के ऊपर यही आपका प्रोस्टेट का यही
That is because, ma'am, they have shown the trends. That means, like previously also in the previous studies also they might have seen the same trend.
आपने ट्रेंड का भी बोला, आपने हमको बोला है
Ma'am, trend. This is for trends only. Average
trend
annual percentage change and trends.
आपका जो ओवरऑल ग्राफ है
हाँ मैम.
उसमें आपने हमें तीन चीज़ तो समझा दिया,
Yes ma'am.
ठीक है, जैसे 4.7% चेंज हो रहा है, इससे हम ट्रेंड कैसे समझें?
Means they compared it to some other previous study also where they have seen the trends.
ग्राफ में ट्रेंड कहाँ है?
मैम इस ग्राफ में नहीं है मैम. They have just compared the
आप
trends. Yes ma'am.
जो सेट
Yes ma'am.
ए बी सी तो हमें दिख गया,
Yes ma'am.
ट्रेंड कहाँ दिख रहा है?
Trend दिख रहा है कि मतलब they have used that color. They have compared it to the previous trends that they have seen, and according to that, if there is increase or decrease, they have seen. This is total average annual percentage change is represented by this number.
Tend to make a one. Change हुआ,
Yes ma'am.
change से means increase हुआ,
Yes ma'am.
and trend is that it is towards the increase. That's
Yes ma'am.
particular
Yes sir. Compared to the previous study that was done.
trend. ऐसा फिगर था, particular यहाँ तो 2004 से ये कम हुआ, स्टेबल रहा या ज्यादा बढ़ता चला है. So this shows that it is increasing. And this means what is the pattern?
Pattern.
It is increasing.
And this is in females. Oral cancer. Highest increase is seen in Ahmedabad urban area. Bhopal stands fourth from above. Least was that is most decrease in average annual percentage changes. Thiruvananthapuram in stomach. The highest increase was seen in Kollam, and the most decrease was seen in Aswal. In case of lung, the highest increase was seen in Kamrup urban, and the most decrease in was seen in Mizoram. For breast,
एक्चुअली इसमें मुझे ऐसा लगता है आप हाईएस्ट इंक्रीज बता ही नहीं सकते. वो जैसे 6.3 लंग का लिखा है ना, संपूर्ण वो बस ये बता रहा है कि मतलब एवरेज 6.3 पहले नहीं था, अब इंक्रीज हो गई, बट कितना इंक्रीज हुआ है ये इस ग्राफ से नहीं पता चल रहा था, क्योंकि कुछ कुछ ब्लू तब भी मैंने गलत बोल दिया था, -4 +4 उसका कोई सिग्निफिकेंस ही नहीं, कुछ कुछ तो 5 तक गए तब भी ब्लू है, क्योंकि उनकी 5% वो मान के चल रहे हैं कि हर साल इंक्रीज होती थी.
हाँ
अब
हाँ
अगर
सर, वो
अब अगर
प्रीवियस
5% से बढ़ जाएगा तो वो कमी होगी, तो सबसे हाईएस्ट इंक्रीज इससे बताना मुश्किल है. बस ये पता है कि हाईएस्ट परसेंटेज चेंज कहाँ पे होता है, बट चेंज इंक्रीज कहाँ पे हुआ है ये नहीं पता, बट हाईएस्ट परसेंटेज एवरी ईयर कहाँ बढ़ रहा है वो पता सकते. एक बार क्योंकि पीछे वाले में लगा, उसमें एक में मतलब उसके आगे जो है वो ब्लू है, जबकि उसके पीछे जो इससे पीछे वाला जो हाँ, अब तो यहाँ पे ये वाला जो रंग में है 1.4, उसमें नीचे ब्राउन कलर है, बट जबकि उसके ऊपर उससे ज्यादा परसेंटेज वाले सारे ब्लू हैं.
वो ना डिजीज स्पेसिफिक स्टैटिस्टिकल सिग्निफिकेंस अलग लग रही है प्रॉब्लम.
हाँ, मतलब ये जैसे दिल्ली में वो 1.4 है, तो दिल्ली के लिए इट माइट हैव इंक्रीज, दैट्स व्हाई द कलर हैज चेंज, बट फॉर अदर स्टेट्स पुणे कोलकाता दैट 1.7 हैज बीन स्टेबल, इंक्रीज हैज बीन स्टेबल.
तो ये स्टेट में तो यहाँ पे डिग्री तो वर्ड नॉर्थ ईस्ट
नॉर्थ ईस्ट में मोस्टली डिक्रीज,
ग्रीन कलर
जैसे इसमें मणिपुर में डिक्रीज हो रहा है, स्टमक डिब्रूगढ़ में डिक्रीज हो रहा है. ये आप फीमेल वाले में थे ना?
हाँ मैम.
ये बहुत क्या कंफ्यूजन निकल रहा है इससे. इसमें है ना, और लंग कैंसर है इसमें फीमेल में, ये वाले चार्ट में सप्लीमेंट में आपने है ना लंग कैंसर का दिया मुझे. ये वाली जो चार्ट बताए थे ना उसमें लंग कैंसर है फीमेल में, फीमेल में ब्रेस्ट और सर्विक्स एक्सप्लेन कर दो।
There has been, like we can see a trend that cervical cancer average uh, annual percentage change has decreased, as we can see from this chart in most of the population. Yes, yes, ma'am.
And breast is
Increasing. Yes.
एक्सेप्ट दिल्ली में उन्होंने स्टेबल बोल दिया, दिल्ली और कच्चर ना, स्टेबल दिल्ली कच्चर और कोलकाता।
No, Kachar is stable. Delhi is increased. Nagpur is stable. Kachar is stable, and Kolkata is stable. This shows trends in age-adjusted mortality rate from 2002 to 2019 for all sites of cancer. And they have shown only a few regions and divided into male and female. So here we can see that Varshi has, in case of males, it is somewhat stable, but it is decreasing as the time goes by. In case of Aizawl, it has a steady increase. Mizoram also. So northeast shows a steady increase in cases.
लाइट ग्रीन क्या है,
Kollam,
बट केरला है ना, कोलम मतलब केरला।
Kerala.
मतलब ऐसा क्या हुआ होगा 2013 में कि सडनली इंक्रीज हो गया।
2016 shows the highest peak.
2013 to 16 कैलामिटी टाइप का कुछ हुआ नहीं।
And then it again shows a decreasing pattern.
ब्लू वर्धा में भी स्टीप इंक्रीज आएगी।
Yes, ma'am. In case of females, Aizawl shows stable age-adjusted mortality rate. Mizoram shows steady increase as well as Mumbai. Kollam also shows a similar trend. We can see a very similar trend in case of males as well as females. In case of Barshi, that is almost stable but decreasing trend. You can see. This is average annual percentage change and trends in age-adjusted mortality rate from 2002 to 2019 in all sites of cancer. In case of Aizawl, it was 1.1, and in case of Vardha, it was 8.5. That is percentage change highest was.
ट्रेंड 1 2 3
Ma'am, they have not explained it. This table they have not explained why they have made trend 1, trend 2, trend 3.
Maybe they put it into 5 year, each 5 year trend. So the number you can hear was include the last.
ये बोल रहे हो ना आप इस टेबल से ही पता चल रहा है ट्रेंड 1 2 3।
So these populations they might have not turned up for the.
पढ़ो ना, ये कौन सी है जिसका एक इकलौती पढ़ो जिसका ट्रेंड 1 2 3 तीनों अवेलेबल
Kollam का
है ना। तो 2006 to 13
three,
ट्रेंड
3.5.
स्लाइड में आ रही है। तो ट्रेंड 1 is 2006 to 13 फोर्थ पढ़ो ना,
Yes, ma'am.
ये फोर्थ पढ़ो ना।
ये fifth है, ma'am.
Right.
मैं बताऊं इसको?
Trend one is 0.9.
तो ट्रेंड 1 is 2006 to 13।
Yes, ma'am.
फिर ट्रेंड 2 पे जाओ, कौन से इयर्स लिखे?
2013 to 16.
ट्रेंड 3 पे जाओ,
16 to 19. Yes, ma'am.
बाकी स्टडीज का आपको शॉर्टर ड्यूरेशन ऑफ डेटा बता दें, इसमें मतलब 10 to 15 days.
This shows top 3 leading sites of cancer based on the relative proportion in PBCRs in India from 2015 to 2019. They have divided into males and females as per region. So here we can see Bhopal, mouth, tongue, and lung cancer is the top 3 in case of males, and percentage of 39.8. In case of females, breast, cervix, uterine, and ovary are the top 3, having 50.6%. Delhi, lung, mouth, prostate, 25.7% in case of males, and in case of females, breast, cervix, uterine, and gallbladder, which is 43.9%. In case of Aizawl, highest 3 were in case of males, esophagus, stomach, and lung, constituting 46.1%. In case of females, breast, cervix, uterine, and lung were highest, constituting 55.3%. In case of Osmanabad and Beed, in case of males, mouth, tongue, and prostate were the top 3, constituting 32.7%. And in case of females, cervix, uterine, breast, and ovary were the top 3, constituting 55.7%.
मैं कुछ जानने की जरूरत नहीं है, बताइए उसका कि आप स्क्रीनिंग करोगे तो किसकी करोगे.
Here it shows mortality to incidence ratio of top leading cancer sites across 43 PBCRs. So in case of Bhopal, breast is 15.4, cervix is 20.9, prostate is 22.2. In case of lung, males 44.9, females is 43.0. In case of oral cancer, males 27.8, females 28.4. In case of stomach cancer, males 38.5 and females it is 23.2. In case of
बहुत इम्पोर्टेंट है ना कि ऑलमोस्ट 50% लंग डाई,
yes ma'am.
भले से ब्रेस्ट ज्यादा हो लेकिन 1/4 विल ओनली डाई. दिल्ली का भी
In
बता
case
दें.
of Delhi, breast 8.1, cervix 8.7, prostate 7.5. In case of lung cancer, males 25, females is also same. Males and females have same value. Oral cancer, males 9.9 and females 9.7. In case of stomach cancer, males 16.4 and females 17.8.
आप कुछ कमेंट करना चाहते हो दिल्ली वर्सेस भोपाल.
कॉमन साइड लंग था, तब भी उनका मतलब मोर्टेलिटी रेट ऑलमोस्ट जस्ट मतलब अबव देन हाफ है, लेकिन ऑलमोस्ट हाफ, मतलब बेटर मैनेजमेंट.
सारी मोर्टालिटी आधी है ना उनकी तो.
Yes, ma'am.
लंग की भी आधी है, ब्रेस्ट भी तो 1/3 है.
इसलिए उनका फिर फैक्ट है.
I think that is more educated people, they are more aware, better access to healthcare. जबकि ये भोपाल आपका भोपाल रूरल नहीं था, भोपाल अर्बन था.
Yes, ma'am.
We are lacking in awareness. और कोई अलार्मिंग जो आपको इसमें बताना स्टेबल. वैसे कश्मीर का भी बहुत अच्छा है.
Yes, ma'am.
ब्रेस्ट की केवल 4.4 है, लंग की भी मतलब कश्मीर इज डूइंग बेटर देन अस.
Yes, ma'am.
श्रीनगर इज डूइंग बेटर देन अस.
29.
Very surprisingly.
26% less from last year.
ऐसा कि आपको भटकना चाहिए, you will expect very good care in human.
Lifestyle behavior and as well as boost TMH.
और प्लस मुंबई में हो सकता है रूरल रिप्रेजेंटेशन है केवल अर्बन की,
नहीं, इसमें अर्बन रूरल दोनों था.
तो उसका भी फर्क पड़ेगा नहीं. Somewhere in middle, है ना? Obviously Chennai and Delhi are doing much better. Surprisingly Mumbai is doing bad.
Patient migration into treatment, ये contributing factor हो सकता है.
क्या?
Patient migration into treatment.
हाँ वही तो आप बोले TMH का कैसे है? 1:100 है इसमें चंडीगढ़ का.
Yes.
तो 100% मर रहे लंग कैंसर, ओरल कैंसर.
In case of Sangrur also, in case of females, oral cancer 100%.
Okay. Internationally also severe कैंसर का डाटा देखेंगे, अगर इस पर लोगों पॉइंट है, it is very high all over the world. Doubting that 50% lung cancer they are surviving.
पर इसमें कुछ जगह मतलब 100 क्रॉस कर रहा है रेशियो. जैसे ये नागपुर के नीचे जो जगह है उसका फीमेल का कुछ 133 जा रहा है, आगे 200 जा रहा है. क्या है वो जगह?
सिंधुगढ़. सिंधुगढ़.
क्लोज ही है. अब कितनी बची है स्लाइड?
हो ही गया ऑलमोस्ट. Key statistical findings were lifetime risk of cancer overall was 11%. Highest risk was seen in Mizoram, 21% males and 18.9% females. For 2024 projection, 1.56 million cases is
मैं
projected.
इसको 21% को बोल सकते हैं ना कि 1 in 5 will develop cancer.
Incidence of death नहीं.
नहीं ये
नहीं, highest risk. And almost 50% split between male and female is estimated now. Estimate cancer cases in 24 total will is estimated to be 1.56 million. Males 7,80,822, females 7,81,277. Leading cancer types.
इसको छोड़ना है. अगर हम आपको बताएं कि इंडिया में टोटल कैंसर केसेस कितने हैं? खोज करके बताएं. ये तो स्टडी उन्होंने पहले की होगी तो उन्होंने प्रोजेक्ट किया है. अब हम देख रहे हैं उनका प्रोजेक्शन सही बैठ रहा है कि नहीं. ठीक है, आपको पता नहीं है, आपको पढ़ना है. बैठ जाओ अभी चलिए.
Leading cancer types in males oral, lung, prostate. In females breast, cervical, and ovarian. So the trend analysis shows there is significant increase in case, and highest was Kamrup urban oral cancer, Thiruvananthapuram breast cancer, Wardha cervical cancer. They have also shown a very interesting trend, that is they have compared from 2015 to 2019 and 2015 to 2020, and they have done a analysis showing the effect of COVID-19 on the incidence rate. So every single region has shown decrease in the incidence rate when we compared it from 2015 2019 to 2015 2020. Yes, sir, they have told that only, that because of maybe not reporting to the centers, it might have shown.
going to hospital.
Yes.
ये ना सब internationally वो बना है, screening program suffered or diagnosis suffered.
Coming to discussion, significant rise in cancer incidence was observed in most of the geographical areas studied. In India, the leading cancer sites were mouth for males and breast for females. Among males, lung cancer emerged as the most frequently diagnosed cancer in southern regions and metropolitan cities, including Visakhapatnam, Bangalore, Malabar, Kollam, Thiruvananthapuram, Chennai, and Delhi. Mouth cancer is predominant cancer sites in the western, that is Ahmedabad or Bhopal, Nagpur, Wardha, central, Barshi, rural Mumbai, Aurangabad, Osmanabad, and Bid, Pune, Sindhugarh, and Ratnagiri, and in certain northern regions like Prayagraj and Varanasi. As tobacco and alcohol use are major risk factors, it is vital to promote widespread education about the harmful effects. In India, breast, cervical, and ovarian cancers are consistently ranked top three most common cancers in women, with disparities observed in survival rates for breast and cervical cancers. The increasing incidence of breast cancer and decreasing incidence of cervical cancers were more associated with generational shifts in risk factors than period effects. Um,
क्या line सबसे last line का वो
uh, the decrease in cervical cancer and increase in breast cancer, it is showing as a generational shift of the entire disease rather than like period effect. Nature of disease का change. And also because now cervical cancer awareness programs are very prevalent, so
that is the main. Increase in the socioeconomic status, increase in the hygiene, and increase in the awareness. These are two reasons why it's cervical cancer.
and because there is a more incidence of obesity, so there can be increase in
अब aging population बढ़ रही है.
That is also, but aging population से जो incidence पर है, इसे मैंने नोटिस की है, उसमें इनकी इंसिडेंस इन इंडिया कैंसर में इंडिया more than a tenth of worldwide cancer cases are presented. About 18.1 million and death is 9 million. इंडिया में जो मैं कॉज बताएं इंसिडेंस के, that is due to increase in the economic status, change of lifestyle and behavior, and tobacco use, greater intake of the alcohol, high calorie food, and decreased physical activity. These are three factors that's why the incidence of the cancer rising in our country. And we have estimated that there will be 12% rising every year. Incidence of the cancer. आप कंप्लीट करो फिर मैं 2-4 चीजों को बताऊं.
This shows age-adjusted incidence rate for all cancer sites from 2002 to 2019 for selected regions only. Yes. Critical analysis. Strengths of the study was a large data set. Geographic diversity was also there. They used average and age-adjusted incidence rate and average annual percentage change for robust trend analysis. And they also did a projection for 2024 to enhance policy relevance. Limitations of the study was mortality data was inconsistent. Only 18% of the population was covered, and then they extrapolated the data to show total population. And underreporting due to incomplete date certification was also there. Thank you.
वेडनेसडे 9:30 हम लोग का रहता है जैसे आपने लास्ट टाइम बोला था ना कि कोई भी टॉपिक में थोड़ा एआई का फीचर हो तो just basically to give us ideas what we can also बोलने पड़ेगा।
लोकली एडवांस मतलब वो बहुत आने वाला है म्यूजिक सिस्टम जैसे जैसे गोल्ड गाने सिस्टम में एंड खासकर ये जो 35
टाटा की तरह से
For introduction of few more our scientists who are participating in Atal Valley Institute of Information Technology, and both they are the experts of the AI of machine introduction.
Hi everyone, I am Narendra Singh Pun. I am from Department of Computer Science and Engineering at ABV IIITM. My expertise lies in area of machine learning and deep learning and its related applications in healthcare sector. So thank you very much for giving the opportunity.
Hello everyone. My name is Sunil Kumar. I'm from again ABB Triple Gwalior, belonging to Department of Information Technology, working in the area of computer vision, AI, deep learning, particularly in medical image processing. I did PhD from IIT Guwahati. Thank you.
Good morning, everyone. Today, the topic of General Club presentation is outcome prediction in older adults with head and neck cancer undergoing chemoradiation. This article was published in JAMA Otolaryngology Head and Neck Surgery on 6th of November 2025. Coming to basics, head and neck squamous cell carcinoma is the sixth most common. Head and neck squamous cell carcinoma is the sixth most common cancer worldwide, with approximately 9 lakh new cases and 5 lakh cancer related deaths annually. Depending on the region and population, up to one half of all head and neck squamous cell carcinoma cases are diagnosed in individuals 65 years or older, a group typically classified as older adults. While management of HNSCC typically involves a combination of surgery, radiotherapy, and chemotherapy, depending on disease and patient characteristics, older adults with comorbidity are often unable to tolerate these intensive therapies. Although some may derive survival benefits from aggressive chemoradiation, others may experience treatment-related toxic effects without clinical benefits. To optimize treatment selection, prognostic tools are needed to identify which patient will benefit from and tolerate intensive therapies. Artificial neural networks offer a promising solution as they have shown efficacy in outcome prediction and treatment customization in oncology. AWN can identify pattern and predictive factors in complex datasets, providing critical insight into patient-specific response that traditional predictive method might miss. I will make a brief intro about artificial neural network first, then we will get back into our article. The artificial neural network are computerized systems designed to mimic how the human brain processes information. Just like the brain uses neurons to process data and make decisions, artificial neural network use artificial neuron to analyze data, identify patterns, and make prediction. These networks consist of layer of interconnected neurons that work together to solve complex problems. Key components are input layer. This is where the network receives information. For example, in an image recognition task, the input can be an image. Hidden layers, these layers process the data received from the input layer. The more hidden layer they are, the more complex pattern the network can learn and understand. Each hidden layer transforms the data into more abstract information. Then comes to the output layer. This is where the final decision or prediction is made. As the picture depicts, the first is the input layer. In between there are the hidden layers. They can be they are depicted two, but they can be many. The interconnection between all them, and they have outformed the output layer, which will goes for the prediction or the outcome of the input data. For easier understanding, there is a table for how the artificial neuron versus the biological neurons have been compared. The structure based in structure, as we have biological neuron, dendrite receives signals from other neurons. In input neurons, artificial neurons, input nodes receive data and passes it to the next layer. The cell body, that is soma, that processes the signal in the biological neuron. In this, we say it like hidden layer nodes, process and transform, which process and transforms the data. Then comes the axon, which transmit and proceeds the signals to the other neuron. In this, we have output nodes, which produce the final results after processing. The connection between the biological neuron known as the synapse, that is the link between the neuron that transmits signal. In the artificial neuron, we call it as weights. That these are the connection between the neurons that control the influence of one neuron to the other. The learning mechanism in the biological neuron comes from the synaptic plasticity. That is change in the synaptic strength based on the activity and over time. In artificial neurons, we term it as backpropagation, which by adjusting the weight based on error in prediction to improve the future performance. In the activation in the biological neuron comes when neuron fire when signal are strong enough to record the threshold. But in activation function, map inputs to the output, deciding if the neuron should fire based on the process data. These are the pictorial diagram for the biological neuron and the artificial neuron. In the biological neuron, the input sites are the dendrites, which goes to the cell body or the soma. When it comes to the axon, and from the axon terminal, that the output data comes in the biological form. But in the artificial neurons, we see there are the input codes. In between, there are the interconnection mating with the linear function and causing the activation function to proceed the outcome or the output. Now, coming back to our article, the study objective is to develop and externally validate artificial neural networks for overall survival and progression-free survival in older adults with head and neck squamous cell carcinoma undergoing definitive chemoradiation. The aim of study was to develop the predictive model using AWN to identify older adults with head and neck squamous cell carcinoma that exhibit a favorable prognosis regarding overall survival and progression-free survival after chemoradiation by leveraging the Shapley additive explanation values to deepen the understanding of the factor driven the model prediction, thereby advancing personalized medicine for older adults in HNSCC. The study design is an international multi-institutional retrospective cohort study. The clinical data from 19 academic centers was collected across Germany, Switzerland, Czech Republic, Cyprus, and US from the senior registry. Study analyzed a specific subset of the senior cohort, an international registry including 1478 older adults which age more than or equal to 65 years, diagnosed with loco-regionally advanced head and neck squamous cell carcinoma, including CT3 and T4, N1 to N3 disease, according to the Union of International Cancer Control and American Joint Committee on Cancer 7th edition TNM classification. Patients with CT1 and T2 and CN0 were not included in this study. This analysis focused exclusively on individuals with loco-regionally advanced HNSCC located in oral cavity, oropharynx, hypopharynx, or larynx, who received definitive radiotherapy with concomitant systemic therapy between January 2005 to December 2019. Approval by the local ethics committee of LMU Munich with the initial database approved by the ethical committee of Freiburg University was taken. Informed consent was waived off given the retrospective nature of the study. The exclusive criteria contains patient with induction or adjuvant chemotherapy, no concurrent systemic treatment, a history of head and neck cancer or previous radiotherapy in head and neck region, or distant metastasis at the start of radiotherapy. Both the standard Carlson comorbidity index and age adjusted CCI were calculated excluding the primary tumor. Overall survival was measured from the start of radiotherapy to the death, whereas progression-free survival was measured from the start of radiotherapy to death, local or loco-regional progression, or distant metastasis, whichever occurred first. Individuals without event by the end of the study were right-censored at their last follow-up. Minimum follow-up of 2 years or a recorded event by the time of data cutoff. Individuals with overall survival with below 2 years were classified as high risk, while those surviving beyond 2 years were deemed low risk. This 2-year threshold reflects the approximately median overall survival in older adult with HNSCC in previously real-world studies. Oropharyngeal cancer with positive P16 expression were labeled as HPV positive. Patients with non-oropharyngeal cancer and those with oropharyngeal cancer lacking test result were grouped together as HPV negative and unknown. Baseline blood value were collected from 0 to 5 days before initiation of chemoradiation. Training and validation of artificial neural network were performed using the data from 14 of 19 centers of the senior cohort, while independent testing model performance were conducted using previously unseen data from remaining 5 centers of the 19. Artificial neural network optimization. We implemented 2 separate artificial neural networks for prediction of either overall survival and progression-free survival. Both artificial neural network models feature a single fully connected hidden layer with exponentially linear unit activation function, a dropout layer, and output layer with sigmoid activation function. All models were trained using the binary cross entropy loss function and Adam optimizer with early stopping to prevent overfitting. These are the technical terms in the in the AI or in the artificial neural network, binary cross entropy loss function and Adam optimizers. These are the things which are taking for correction of the system, that our software is predicting a right value or not. By this, we used to check binary cross entropy loss function and Adam optimizer. For each endpoint, a separate hyperparameter search was performed based on the training set, which further split into the actual training of 80% and validation of 20%. A total of 192 hyperparameter combinations were investigated. These hyperparameters are the combinations of the input codes which we have given to the data software, from which in the hidden layer they are processed to come out for the output thing. Specifically, we varied the number of neurons in the hidden layer as 10, 15, 25 and 25. The dropout probability is 0.25 and 0.5. The batch size is 32 or 64 and the weight decay is 0 or 0.001 and the optimizer learning rate is 0.0005, 0.00010 and 0.00050 and 0.0010. Statistical analysis involves the calculation of Kaplan-Meier estimates for survival outcome with log-rank tests used to compare difference between the high risk and the low risk group. We also determined the receiver operating characteristic, area under curve, precision recall, and Harley index. The ROC area under curve value evaluates the model ability to distinguish between the classes, providing measure of how well the model can identify true positive across the various threshold setting. The precision recall area under curve value emphasizes precision, that is true positive among the predicted positive and recall true positive among the actual positives. While the no skill value for ROC AOC is always 0.5. The no skill value for the PR AUC depends on class imbalance and is defined as a portion of positive samples relative to all samples. Number of the positive samples upon the total number of samples. To compare the artificial neural network with other approaches, we implemented an extreme gradient boosting, that XGBoost model, a tree-based assembly learning method designed to capture non-linear relationship and interaction among input variable for direct overall survival and progression-free survival prediction. We also applied univariate Cox proportional hazard regression for ECOG performance status score, HPV, and N classification. In addition, a multivariate Cox proportional hazard regression model was performed to estimate the relative risk of overall survival PFS using the same set of input variable as for the ANN and XGBoost model. Data were analyzed from December 23 to April 2025. In the results, we see that the patient population of 898 were included in overall survival analysis, from which 738 were taken in the training cohort and 160 were taken in the testing cohort. As such, 945 included in the progression-free survival analysis, from which 770 were in the training cohort and 175 were in the testing cohort. In the overall survival cohort, 665 patients were male and the median age was 71 years. And for the progression-free survival, 696 out of 945 patients were male. The median age was 71 years only. From the overall survival training cohort, that is the 738 patients, most tumor were located in the oropharynx, that were 420, followed by the hypopharynx, 111, and the oral cavity, 91, and larynx, 91. Most patients have ECOG performance status score of 0 to 1, that is 640 of 738, and the median age adjusted CCI Carlson comorbidity index score was 4. Within the cohort of patients with oropharyngeal carcinoma tumor, 200 tumors were HPV positive and 149 were unknown cases. The most common systemic treatment regime was cisplatin, cetuximab, cisplatin plus 5-fluorouracil. The median cumulative cisplatin dose was 180 mg per meter square. Radiotherapy was completed in 666 patients with a median equivalent dose in 2 gray of 70 gray with a sensitivity of 10 gray. This alpha by beta ratio shows the radiation sensitivity of the tissue. If the score is 10, the tissue will be more sensitive and the least score will be 3. Some biological tissues like renal tissue, they show a sensitivity of 2 gray only. They are the least sensitive to the radiation. After a median follow-up of 68 months, the median overall survival was 50 months and the median progression-free survival was 34 months. At the analysis, 428 patients of 738 patients had died. The independent, that was the data shown previously was from the training cohort. Now comes the independent testing cohort. It includes 160 patients from the overall survival analysis and 175 for the progression-free survival analysis from 5 tertiary cancer centers. ECOG performance score was slightly less favorable in this training cohort. That is, with 119 patients, we have seen the score of 1, and in 29 patients, we have seen the score of 2 or greater. Within the cohort of the patient with oropharynx carcinoma, 38 tumor were HPV positive, and 28 patient of oropharynx carcinoma, HPV status was unknown. Cisplatin, mitomycin C, and cetuximab were the most commonly used systemic treatment. The median cumulative cisplatin dose was 200 mg per meter square. Radiotherapy completion was at high at 93%. That was 90% in the training cohort. Here it is the 93.1% with a median equivalent dose of 70 gray. After a median follow-up of 73 months, the median overall survival in testing cohort was 39 months and the median progression-free survival was 25 months. By the time of analysis in this testing cohort, 98 patients have been died. Artificial neural network details. For overall survival, we have found the hidden size of 25, a batch of 32, a weight decay of 0, and dropout rate of 0, resulting in the best validation accuracy. The median prediction score later used as the testing stratification threshold was 0.36. For progression-free survival, we found a hidden size of 25, a batch of 32, but a weight decay of 0.001 and dropout rate of 0.5 to lead the best validation accuracy. That was 0 and 0 in comparison for the overall survival. The median prediction score later used as a testing stratification threshold for progression-free survival was 0.48. The developed artificial neural network exhibit rapid loading and interference time of less than 5 milliseconds. The survival analysis for artificial neural network was during optimization. The model achieved ROC of area under curve of 0.78 and the precision recall of area under curve of 0.67 on the internal trailing and the validation set, substantially outperforming the no scale precision recall area under curve baseline, which was taken as 0.36 for overall survival. In the context of overall survival with the independent testing cohort, 160 patients met the inclusion criteria. The artificial neural network categorized 101 patient as high risk and 59 as the low risk. The Kalpan-Meyer survival analysis demonstrated a significant distinction between the high risk group and the low risk group, which will be depicting in the figure 1 using the artificial neural network. Additionally, the model achieve a ROC under area under curve of 0.68 and precision recall area under curve of 0.57. Compare with the no skill precision recall of area under curve is 0.36. The C index was 0.66. This is a curve for Kalpan-Meyer survival curve of the difference in the overall survival between the low risk and the high risk patient group. The y-axis show the overall survival and the x-axis show the time in the years. As you can see, as the time in the years increases, the overall survival percentage decreases. The 0.2 and 0.4, 0.6, these depict the 20%, 40%, 60% survival rate, overall survival rate. As the time increases in years, the overall survival rate decreases. As in starting, it is showing in the high risk number group, there are 101.
पावर स्विच कौन सा उसमें जा रहा है?
ये जा रहा है।
एक बार आईटी को भेज दे, नहीं तो उसका प्लग बदल दो। फिर बाद में
I think power आ रही है उस right? अच्छा
लो बैटरी
low battery. Power आ रही है adapter on.
वो दबा
Maybe इसको
बैटरी प्लग है।
पावर पे आने के बाद कंप्यूटर
So in the high risk number, initially the patient were at risk of 101 and in the low risk group, the patient were risk at the 59. But as the year goes on, that the 2 year, 4 year and 6 year, we see the patient were at risk at the 56 and events which were happened eventually changes and increases. That like in the 2 year group, we see the high risk individual have the event of 45 and the low risk there are the 13 individuals. But in the 4 it eventually increases to the 64 and 21 respectively. But at the 12 year of 12 year of gap, we have seen that the 70% of the events were taken place. Only one individual have been left with the risk category and 30 patients were being censored. In the low risk category, one patient was at risk, 30%, 30 individual were censored and 28%, 28 individual were haven't had the event before only. The B chart depicts the representative operating characteristic curve in which the baseline was taken as the 0.5, that is the no scale ROC AOC, which you can see the dotted straight line, and the linear exponential curve which is seen above shows that there the good predictability of the software, that it's showing the true positive number of cases in comparison to the no scale ROC UAC, which is taken as the 0.5. In the precision recall curve, we can also again we can see in the y-axis that is the precision, and then the x-axis that the recall true positive rate. The no scale precision recall area under curve was taken as 0.36. The whole data which have been signified by the our software was above the 0.36, which depicts that it have a good predictability towards the outcome. HPV status had the highest impact on the model. Absolute SHAP of 0.48 followed by GFR, ECOG performance status score and nodal classification with mean absolute SHAP value of 0.46, 0.43 and 0.39 respectively. Other features such as C-reactive protein, T classification, or tumor site showed lower mean SHAP values and thus less impact on the artificial neural network. Figure 3 displays the individual dependence plot for HPV, EGFR, ECOG performance status score, and N classification within the independent testing cohort, where positive SHAP value suggested the high risk and negative value indicated the low risk. In this first A figure shows the bar chart depicting the mean absolute SHAP value for overall survival, offering a ranked visualization of feature importance based on their average impact. They have been assembled according to their status, that which criteria will affect mostly to the SHAP values, that like HPV status, EGFR, then ECOG performance status score, and classification, C reactive protein, and thereby further list have been gone on which show low effect criteria on the SHAP values, which make predictability of the software less interpretable. B is the SHAP B swarm plot for overall survival, in which we see the color depicts the higher feature value and the horizontal area depicts whether the effect of the value is associated with higher or lower prediction. In this case, we are seeing that the HPV status having the negative value but have a higher feature value depicting in the red, which having a good mean status of the SHAP values. But in the things of sex, creatinine, leukocyte, hemoglobin, and age, there is the least mean value which can be considered of the mean SHAP value, which will have a least effect on the overall outcome. So thereby HPV, EGFR, and ECOG status were the main criteria which were be making more hyperparameters, of which will be more analyzing the outcome of the software, because they have the more SHAP median values. It is the individual plot for the partial dependence plot for top 4 feature regarding the overall survival. In this we can see that if the in the first chart, that is the HPV status, one is the positive and second is the negative. As earlier shown, that positive SHAP value will indicate a high risk and negative SHAP value will indicate a low risk. So if the HPV status is positive, we eventually know that the patient will be categorized as a low risk patient, and in the HPV status is negative, it will be a high risk category patient. So it is depicted in the chart that SHAP value is 0.2 to 0.4 for the 0, that is the negative HPV status, and for the positive, that is 1, it is in the negative value of 0.08 to 0.1. As if goes on to the further, that is the EGFR at the baseline, we have taken the 70 milligram per 70 ml as the baseline. So the value lesser than 70 have the more positive SHAP value, that is the more higher risk group, and value more than 70, which gives the better clearance and the more chemotherapy effect to the body, have a negative SHAP value. Going further to the ECOG, more the ECOG score, the higher risk group the individual will, depicted in the chart, the 0 and 1 in the negative SHAP value. So they will be, the patient will have good outcomes, so they were taking the low risk group, and the patient with 2 and 3 have the positive SHAP value, so they will be in the higher risk group. Further, the N classification, the more the number of N, like N0 have the most negative value of 0.01, negative 0.01, which depicts it's a low risk group individual. As the N value increases, the patient have been transformed into the high risk group. In the PFS analysis of independent testing cohort derived from 5 centers, that is N175, the artificial neural network labeled 73 patients as the high risk and 10 patients as the low risk, yielding a significant difference between the both group. The ROC area under curve was 0.64 and the PR area under curve was 0.66, compared with no skill PR of area under curve of 0.53. The C index was 0.62. In the internal training and validation set, the model achieved a ROC area under curve of 0.70 and precision recall area under curve of 0.65, outperforming the non-skill precision recall area under curve baseline of 0.47. This is the chart for Kaplan-Meier survival curve of the difference in the progression-free survival between the low risk and the high risk group, as initially described for the overall survival. This is meant for the progression-free survival. In this also we can see that as the year passes by, the progression-free survival of the individual percentage decreases down. That initially there were the 73 patient in the high risk category and the 102 patient in the low risk category at the year 0 at the starting, but as the year advances, like at the 6th year, we see that only 6 individuals left with the risk and 57 had the event, and 10 patients were censored. And in the low risk category, there are 20 patients with the risk, 18 were censored, and 64 had the event. For as previously described with the numerical values, this is the ROC curve for progression free, in which the no skill ROC area under curve was taking 0.5, but our model have depicted the ROC area under curve was 0.64. That shows it have a good probability of outcomes. For the precision recall curve also, the no skill PR area under curve have the value of 0.53, but we had the PR area under curve value from the software is 0.66. The depiction comes from the chart only. Based on the mean SHAP value of progression-free survival, human papillomavirus status emerged as the most significant influential feature, followed by the age-adjusted CCI score, CRP, and the nodal classification. Variables such as sex, tumor site, ECOG performance status score, smoking history, and hemoglobin level show minimum impact. Again, for the progression-free survival, the plotting have been done for the SHAP additive explanation mean values. Firstly, the log type are being given, but in this you will see that the criteria have been changes. The HPV status is followed by the age-adjusted CCI score. Initially, in the overall survival, that was the EGFR was there, but in this we have the age-adjusted CCI score. Then with the CCI score, then CRP, then N classification. Least comes with the age and leukocytes and hemoglobin grading, which have least eventual effect, or the least mean value, which will affect the overall outcome of the software. Second, B plot shows the B swarm plot for the progression free survival, in which we see the higher feature value, which is depicted in the red, have the more mean sharp value, which will be from towards the negative. So if the case is positive, if we take the HPV status positive, the patient will be in the negative SHAP value, so it will be a low risk category group. But if the patient comes with the higher, in the case of EGFR, we can see the mean SHAP value will be shifted towards the positive side, so it will be a high risk category group. The comparison of the model performance with the other model was also taking. The prognostic performance of the artificial neural network was compared with other approaches, including an XG-boost model and Cox proportional hazard regression model. Among all tested models, the artificial neural network demonstrated the highest prognostic accuracy. For overall survival, the representative operating characteristic area under curve were 0.68 and for the artificial neural network, and 0.57 for XG-boost model, and 0.65 for the multivariate Cox proportional hazard regression model. For progression-free survival, the corresponding ROC, AOC values were 0.64, 0.62, and 0.60 respectively. Now comes to the discussion part. Based on an international multi-institutional cohort study with the patient data from 19 centers, we developed and trained an ANN for both overall survival and progression-free survival prediction of older adult with HNSCC undergoing definitive radiotherapy with concomitant systemic therapy. Both models effectively stratified older patients with head and neck squamous cell carcinoma in an independent test cohort into high risk and low risk group. The ROC area under curve of 0.68 indicate competent but still improvable performance, particularly giving the class imbalance inherent to the head and neck squamous cell carcinoma. Notably, the artificial neural network demonstrated the rapid loading and interference timing of less than 5 milliseconds. In a related study by the Pan et al., applied XGBoost model to oropharyngeal cancer, integrating the radiomimics feature from pre-treatment computer tomography scan with clinical data, used the least absolute shrinkage and selection operator sequential floating backwards selection algorithm. Their model achieved ROC AOC and PR AOC score of 0.85 and 0.79 respectively. That is more better than our software that was 0.68. But again, other study of Han et al. Further incorporated the PET scan and the CT and dose distribution data into the deep learning AI model. So they have also achieved an average area under curve of 0.86 for predicting local recurrence after radiotherapy without clinical variables, and 0.89 when clinical variables were included. While these approaches yield higher performance metrics, our approach is streamlined and relies solely on easily available clinical variable. We haven't included any radiographic data or any other data, offering high accessibility and feasibility by extending the analysis beyond the oropharyngeal cancer to the broad head and neck squamous cell carcinoma population. By identifying the key features such as HPV status, kidney function, ECOG performance status score, and NN classification, our findings closely align with established clinical knowledge, thereby reinforcing the relevance of these factors for clinicians. Our SHAP analysis revealed that the primary predictor of high risk status for overall survival were the negative HPV status, decreased EGFR values, poor ECOG score, and advanced nodal classification, whereas all other variable extended the small influence on the overall outcome. Significant results for progression-free survival, though with a distinct set of features: negative HPV status, high adjusted CCI score, elevated CRP values, and advanced nodal classification were the most important feature for assigning the patient in the high risk group. HPV status emerged as a strong predictor of overall survival and progression-free survival, underscoring the role of HPV in treatment response of older adults with oropharyngeal cancers. Pre-treatment EGFR level were emerged as the second most significant predictor of overall survival, with values of 70 milliliter per minute, 1.73 meter square, indicating the improved survival. Both age-adjusted and the non-age-adjusted ECOG performance score and CCI score emerged as a significant predictor of overall survival and progression-free survival, underscoring the critical score of functional status and comorbidity. ECOG performance status score of 0 to 1 were associated with the better survival, and whereas the score of 2 and 3 signaled the higher risk. While tumor-specific factors such as nodal classification exhibit a significant prognostic value of overall survival and progression-free survival, chronological age itself only played a minor role. This underlines the importance of more nuanced assessment of biological age and functional status rather than relying solely on chronological age in clinical decision making. Factors such as comorbidity burden, performance status may better capture a patient treatment tolerance and prognosis and should be prioritized when considering definitive chemoradiation in older adults. The limitation of this study was firstly the retrospective design inherently introduced the potential selection and information bias. Additionally, important clinical values such as standardized geriatric assessment score and nutritional status, blood-based biomarker including albumin and neutrophil to lymphocyte ratio, and biological parameters such as level of tumor infiltrating lymphocytes or tumor hypoxia were not available, potentially limiting the model comprehensiveness. The absence of imaging derived parameters such as gross tumor volume of the primary tumor and involved lymph nodes may further constrain the predictive performance of the artificial neural network. Moreover, tumor staging was conducted according to the UICC and AGC 7th edition, which lacks the improved prognostic discrimination for P16 positive oropharyngeal cancer provided by the 8th edition. Lastly, treatment-related factors such as radiotherapy parameter and the type of systemic therapy, including cisplatin versus atoximab, were not included in the prognostic model, as our goal was to develop model applicable at the time of initial presentation. Despite these constraints, our work leveraged the extensive senior cohort, which is one of the largest dataset of our older patient with head and neck squamous cell carcinoma, receiving curative radiotherapy gathered from the multiple centers across Europe and US, with a robust training set of 770 patients for progression-free survival and 738 patients for overall survival, an independent testing set with the data of 5 centers of 175 and 160 patients respectively were taken. Overall, artificial neural network model demonstrates strong reliability and broader applicability. Conclusion: artificial neural networks successfully stratified older adults with head and neck squamous cell carcinoma into high risk and lower risk group for overall survival and progression free survival. By incorporating the SHAP values, the model offered transparency and interpretability, marking a significant step forward in personalized radiation oncology. Thank you.
Well, extensively covered, very good presentation, completely. And of course, topic is new and important in the sense that this study was done mainly in the older adult patients. There is a classification given by the United States Aging Society, and they have classified the older people into the three category: young old, or young old means 65 to 75, and 75 to 84. They were the older gold, and more than 84, they are the oldest people. So that was the classification of the American Society for Aging. Now here, in this study, they have included the people more than 65 years of age. And why it is specifically important in head and neck cancer patients of our country, that when we see any patient of that age group, suppose a patient comes in the age group of the 70 years, clinician and family member, first they decide whether to give any anti-cancer treatment or not. This is the first thing, that by giving treatment, we may not be making the life of the patient more troublesome than whatever or she really admitted. But there were various studies, clinical trials, where they have proved that if you don't treat the patient, then overall survival is less than 6 months. Somebody survived for 4 months, 5 months, or 6 months. But if you treat by either radiotherapy or radio chemotherapy, overall survival increases. If only radiotherapy, it may go up to the 14 months, 15 months, and you combine with the radio chemo, it further increases. So as mentioned in the last, that it is the biological age which is important, not the chronology. Now, this is an important question, that which patient should be treated and which should not be treated. Because people of this age group, they have lot of associated comorbidities. So there are further trials in which they found that only 60% of the patient, when they advise the treatment, they could complete the treatment. Rest of them, they discontinue the treatment in between because of the comorbidities or toxicities of the treatment. So it is important to assess that which patient, after giving the treatment, is really going to get best benefit, so that we can counsel the family members, because family members is also reluctant. कई ऐसे फैमिली मेंबर्स आते हैं ना, बोले साहब वैसे तो जितने जीने थे जी लिए, अब ये एक कष्ट नहीं हो, जितना जीवन है आराम से निकल जाए. एक की कॉमन साइकोलॉजी होती है, जब 70 ईयर्स का या 60 पेशेंट आता है, तो उन्हें अभी तक तो कभी बीमार नहीं हुए, अब ये एक कष्ट नहीं हो, जीवन निकल जाएगा, ठीक मेंटलिटी है. But by scientifically, if we see and if we know that by offering the treatment to the patient, we can increase the survival time without compromising much sometimes, because we have to compromise. Once you give the treatment, there are some morbidities associated with the treatment, and if patient is already having morbidities, then those complications aggravate further. So this type of the study is very important, so that in that age group also, we should not just give big vehicle of इतना था घर ले जाओ or symptomatic treatment. We can offer the treatment, but before offering the treatment, if we know the prognosis, if we know the probable outcome of the treatment, then that is definitely going to add in making the patient more convinced for taking the treatment. So it's a good paper, really good study, and as we are in a tertiary cancer center, so we have to see that such type of studies, whether we can do in our institutions also, making all other parameters. We can, this is only the clinical findings which they have included in this, but whether we can include imaging also to develop a neural network, can help in predicting the outcome. So it's open for the discussion, comments, suggestion. Please go ahead.
The multimodality thing, like it always helps in improving.
No,
clinical.
those studies are there, that whether you are treating only by radiotherapy or multimodality, means including the
Clinical.
including the chemotherapy, or you are including the biological therapy or immunotherapy. Of course, that is impacting the survival.
मतलब इसमें इम्पोर्टेंट क्या है कि हमने पैलिएटिव पेशेंट को नहीं लिया था, हमने क्यूरेटिव पेशेंट्स को लिया था, और उसमें भी 2 साल में 60% मर गए. तो वो 60% मर रहे हैं, तब भी हम उनको CTRT देना चाहते हैं या नहीं, विच हैज इट्स ओन टॉक्सिसिटी. तो अगर उन्हें लो रिस्क हाई रिस्क में डिवाइड कर लो, तो हमें समझ आ जाएगा कि किसको देना है, किसको नहीं देना. और ये कि हम आइडेंटिफाई कर लें. अभी हम कैसे डिसाइड करते हैं, हम डिसाइड करते हैं स्टेज की बेसिस पे. तो इन्होंने जो पैरामीटर्स दिए वो स्टेज से आगे के भी पैरामीटर्स दिए. एक आपने वो वाला जो ग्राफ था ना, 2 ग्राफ है जिसमें बी सॉन्ग और वो दूसरा वाला। अब इसमें जैसे हम नीचे कुछ कुछ है जो हमें जो टीएनएम स्टेज हम लिखते हैं उसमें आ जाता है, जैसे साइज ऑफ द ट्यूमर आ जाएगा, एन क्लासिफिकेशन आ जाएगा, टी क्लासिफिकेशन। लेकिन इसमें बहुत सारे पैरामीटर्स हैं जो हम स्टेजिंग में यूज नहीं करते हैं, विच इज जो कोमॉर्बिडिटी इंडेक्स आ गया, हीमोग्लोबिन और इस टाइप की चीजें, जिससे हमें और कॉम्प्रिहेंसिव पता। एक क्लिनिशियन के लिए बैठ के ये सारी चीजें कंसिडर करना ओपीडी में, उसका इन्फेरेंस निकालना, मतलब 1 घंटा भी नहीं, 1 दिन से ज्यादा हो जाएगा। इट रिक्वायर्स टू अबाउट एवरीथिंग, और यहाँ पे आपने बोला 5 मिली सेकेंड्स में आपको एक
Yes, ma'am.
रिजल्ट मिल रहा है। तो ये इसका बेनिफिट है कि ये एक्स्ट्रा इन्फॉर्मेशन इंक्लूड करके हमको रिजल्ट बता रहा है। और तीसरी चीज जो मैं हाईलाइट कर रही हूँ, इनका जो ट्रेनिंग के बाद वैलिडेशन था, 5 centers में 176 पेशेंट्स। I think we can get 176 patients from our institute only in 2 years. So we don't even need इनको तो 17 सेंटर, 5 सेंटर लग गए अपना हेड एंड नेक बर्डन, क्योंकि दिस इज आई थिंक यूरोप बेस्ड
Yes, ma'am.
है ना, आपने जर्मनी
Germany.
तो अपने हमको कितना ज्यादा डेटा सेट मिल सकता है। एक आपकी लाइन थी ANN, XG बूस्ट और मल्टी वेरिएबल एनालिसिस, लिमिटेशन के पहले या डिस्कशन के पहले थी वो स्लाइड। XG बूस्ट क्या है ये सब?
मैम एक्सी बूस्ट एक और मॉडल है, वो नॉन लीनियर मॉडल है। जैसे हमने ANN को लिया है, ये एक लीनियर एक्सपोनेंशियल मॉडल था। एक्सी बूस्ट एक नॉन लीनियर मॉडल था जो उसको कंपेयर कर रहा है कि हमारी जो हमारा ANN का हमने जो मॉडल है हमारा, दैट हैव अ गुड प्रिडिक्टिविटी और नॉट, उससे हम एक्सी बूस्ट के थ्रू कंपेयर कर रहे हैं उसे। कंपेयर द मॉडल था।
मतलब XG बूस्ट भी AI बेस्ड ही होगा।
वो क्लासिकल मॉडल
Yes.
Both are ANL and FBA, both are non-linear. NN is also non-linear.
Non-linear.
But since they are different, ANL has basically inspired from the brain. Execution is basically based on decision tree. It's tree-based model.
like rule based.
This is ensemble tree-based model. Where
So
basically-
multiple different trees are assembled together and their aggregated decisions are delivered at the outcome.
Okay. मतलब ये टाइप्स ऑफ टेक्नोलॉजी हो गई।
Yeah, types of.
यही था क्या डिस्कशन के एक स्लाइड पहले, क्योंकि उसमें ये पता चल रहा था कि विच वन इज बेटर, किसका AUC ज्यादा आ रहा था। इसके एक पहले का था मतलब देखो पब्लिकेशन भी है, अब वो सप्लीमेंट्री मटेरियल हम एक्सेस नहीं कर पाए थे इसका।
I think on
Wait,
why this model will work. Generally, we won't publish this kind of thing. Really, I'm talking about this particular framework, I don't know. If we publish this kind of work, our paper will throw something, like anything. Because this model is not valid in fact.
yeah.
But one line I can say, because the data that what we have is times data. It's basically collected over 2 years over time. And the model that we have used is basically not valid for time series data. And therefore, the entire work is, I think,
what does it mean? Times about that.
the data basically, for example, the what, am I right, correct? Poon?
One is temporal data, and there is like normal.
If you have time series data, means let's say today you collect some data, and if it is influenced from the previous data, because whatever the data which is coming, today's whatever symptom, whatever you are getting, if it is influenced from the previous one, yesterday's data, right? Then this sort of model, the NL with one single hidden layer is not valid. We have another class of model which is particularly valid for this kind of a sequence problem. We can say RNN,
RNNs are
LSTM, transformer. These kind of models are basically valid for this kind of analysis.
Sequence.
And therefore, this work technically is not relevant. I don't know why who had published this one. I'm sorry, sir. I'm just telling because technically, I am just talking. We three.
I think
We three are basically agree. I don't know.
If I can just say something, इनका देखो इन्होंने स्टडी तो बहुत पहले की होगी,
Right.
and science is advancing every day, पेपर पब्लिश करने
That is why, sir, man, we are basically we want to see the data.
Yeah, यहाँ पे मतलब ये भी है कि like it is a multi-center study. Multi-center study is very rare. So if this kind of study makes the approach more generalizable, like कि it can be applied on multiple kind of data. But approach I agree.
How they consider the times the data into the
well, is there any pre-processing?
they will be right.
डेटा बोल रहे हो मतलब आप बोल रहे हो कि हम एक पेशेंट को मल्टीपल पॉइंट्स पे स्टडी करें तो अगर जैसे उन्होंने रेट्रोस्पेक्टिव डेटा लिया है कि ये डेटा हो चुका है मतलब
एक ही बार
हाँ yes, yes,
कैसे
नहीं मतलब ये है कि 2000
Retrospectively, it is the
मतलब 2010 में कोई पेशेंट आया है उसने अपना पूरा ट्रीटमेंट वगैरह ले लिया 2012 में देखा था या मरा था टेबल पे एंटर कर दिया अब हम 2015 में बैठ के उसको एनालाइज सो एवरीथिंग इज ऑलरेडी हैपेंड बिकॉज अगर हम काउंट करें
Time series model.
so instead of
अगर-
ALM we are suggesting a different model.
हाँ, अगर if we have done some pre-processing on that window, then you combine that window data into certain one quantity, then that will work.
That's
Then
what
that
we
will work. So, is there any pre-processing done on the data set?
Reprocessing मतलब
Like before feeding into the neural network AI को, तो उससे पहले कुछ noise किया या कुछ out है?
obviously don't बेसिकली कुछ गाइडलाइन जैसे कि स्टेज एडवांस होगी तो प्रोग्नोसिस खराब होगी ये चीजें तो वैसे भी स्टैब्लिश्ड है वही हमने एआई के को इनपुट दिया होगा
It's a very simple model. One
हाँ,
can modify this model in very different way. This is the, I can say, simplest model.
there is foundation
Simplest model.
foundation model.
क्योंकि हम
Want to discard it because it is simplest.
Not, I mean, we
Any
accept
study,
the
any study, we start. We start with simple and then this is more and more complicated. So when they thought of doing this study, that whether ANN can work to predict the prognosis of the patient. As I said, that they have done this study in the elderly population. And prognosis in the elderly population is not good. It's bad prognosis. Head cancer in the elderly. And as said by Dr. Bunyan and I also, that before start of the treatment, we just want to know that what is the probable prognosis and survival of this patient, so that the type of the treatment which we are going to offer the patient should not deteriorate the quality of the life. We may increase the survival, but at the same time, there are associated comorbidities. So overall survival may not change, but the quality of life for that 6 to 8 or 12 months may be deteriorated. Simple model was put by somebody, did this study, and now we have more complex and advanced. So the idea of having this meeting today, besides the presenting this paper, study published in Germany, that whether, as you said, that now there are better models, better things. Those better things can be utilized. That is the idea. You see, we whether we can do something better than what they have done, and we can incorporate some other.
We're not kidding. The doctors means we publish this kind of work. We always think behind you whether doctors will accept our work. And now we are with the doctors. When we try to publish, now we think whether doctors will accept our this analysis.
Science is advancing every day. And especially in artificial intelligence is such a branch where every day we are getting some new so things then start from scratch. You see, as I was telling that I guided a PhD thesis in cancer breast use of AI in diagnosis of the cancer breast, and this is some, I think 8 to 9 years back. I guided some PhD for that. And now things have advanced from that time. Of suppose if somebody comes and discards that birth, what nonsense they have done. What we have done 8 or 9 years work back. Now things are better. Things have advanced. Naturally, today's time, you may do a further better work and better.
That is why we want to be concerned with the 3% part that Dr. Poli suggested. How they have converted this problem to this particular phase. Then this work is valid. I'm not telling this work is not valid. Probably they might, because this is work done by in Germany, they have done some processing and converted the time series framework to a framework where this model is valid. This is the correct.
एक चीज मैं समझना चाह रही थी, जैसे इन्होंने इतने सारे पैरामीटर सिस्टम में फीड किए होंगे और इन्होंने एक कट ऑफ वैल्यू निकाली जो कि ट्रेनिंग पीरियड में, फ्रॉम व्हाट वी अंडरस्टूड कि इन्होंने जो 15 सेंटर्स का डेटा था जितने का भी उन्होंने ट्रेनिंग मॉड्यूल में डाला और उन्होंने उसमें से कट ऑफ निकाला, तो वो हमें कंप्यूटर को बताना पड़ेगा ना कि आप कैसे उस लेवल पे आओगे.
They have seen in the last year they use sigmoid function, right? Sigmoid function they have used, right? I talked about myself.
What does mean? We don't know.
Generally, basically, it's a probabilistic. The output what we get this is probabilistic value. If it is greater than 0.5, we classify it as high. If it is less than 0.5, it is classified as low value, right? So that's sigmoid. The graph is the graph of sigmoid that basically used to classify and input data to one of the class, two classes. It's a binary class problem. Am I right, sir?
But in the actually, I have learned a little bit about it. It has shown that with the value of 1, it give a best predictability.
That is ideal. Nobody
Yeah, that's the ideal.
that is
But
the
above
ground
0.7, it have taken 0.7 to 1. That's a good value. But from 0.5 to 0.7, they have that more can be done to improve that. And below the 0.5, they have sent.
What is this the ground? When we prepare the data for training the model, so we have the input patient data with the class level. This is the class level. So we generally, we as a doctor, we know that this patient is will belong to this class. So we give 1. 1 is the ideal value. The model will never will give you 1. Model will give you 0.8, 0.7, 0.9, right? So if it is
How does जैसे वो जो ग्राफ था जिसमें उन्होंने डिफरेंट पैरामीटर्स का इन्फ्लुएंस बताया था,
right,
ये वाला, तो ये मॉडल कैसे डिसाइड करेगा?
class, Dr. Poli.
This comes under the part of explainability part. Once your model is trained, why that particular resistance is classified into certain category is what this figure depicts. The way Shapley works is again technical algorithm which tells you the contribution of particular feature towards the current prediction. Maybe if you give some other instance, maybe the importance of the parameters may change for that particular instance. It's possible. So given that particular instance, what were the features important for the prediction of that instance? So that is what it's.
Yes. Okay. For example, let's say you're looking at me right now. You're able to recognize who I am. Okay. Now, can you with my eyes? But you can still maybe if I give you like 100 number of eyes, this eye is then you might get confused. Okay, so this is one feature. This is another feature. This is another feature. So these are different features that helps you recognize me. When all the features are together, definitely 100% you are able to recognize me. But when only this feature is there, maybe this feature is the more dominating. That's able. Yeah, that's why it is your input is
Out of these sub window and these are basically input to your model. The left side is these are the features.
These are the features.
Which feature contributes more towards the write-off? That tells you
Which is more dominant.
which
That
feature is more.
machine is automatically going to conclude.
Yes, the way you are doing it.
able to
The way you are doing it.
The difference.
फीड कर रहा होगा ना उसको पहले कि ये वाली चीज ज्यादा चांसेस है.
आप कैसे करते हैं?
The rules which you learn is like automatically learned in the AI, unlike classical problem. Classical में correct.
ANN is a black box. We say the N is a black box.
It will automatically adapt to the rule how to categorize.
Part explain the internal part of the how NN predicts the right thing. The part helps you to uncover the.
With this, you are getting the idea like based on the HPV value, it is getting predicted into this. It is causing more contribution towards it.
I believe each simple, just like I said, a simple word. If I can use simple RNN instead of simple ANN, probably the entire analysis will revolve.
Your statistical parameters will definitely improve.
Simple RNN, simple RNN.
Recurrent neural.
Recurrent neural.
ट्रेन करते रहता है.
ये तो मैं ट्रेनिंग तो बिल्कुल
देखिए आप यू मस्ट हैव जीमेल यूज करें व्हेन यू टाइप कंपोज एनीथिंग
हाँ
कोई मेल लिखते हैं तो बोलते हैं टुडे आई एम, तो वो खुद ही सजेस्ट करता है गुड, तो गुड सजेस्ट कर रहा है, कैसे सजेस्ट कर रहा है पीछे के डेटा पे
बेस्ड प्रीवियस
लास्ट 3 डेटा 4 डेटा उसने लिया, उसके बीच में होता है गुड लिखना चाहते हैं नेक्स्ट, ऐसे व्हाट्सएप में भी आ गया, टाइप करते हो तो वो ऑटो करेक्ट
ऑटो सजेस्ट
ऑटो सजेस्ट वो कैसे कर रहा है टेक्स्ट के बेसिस पे कर रहा है
प्रीवियस टेक्स्ट
प्रीवियस सिंगल हमारा बॉडी जैसे से कोई चेंज हो रहा है, एंटीबॉडीज चेंज हो रही है, कुछ भी हो रहा है, तो वो एक प्रोग्रेशन है चेंज होने का, ऐसा नहीं कि आज था कल खत्म हो गया, इट विल टेक सम टाइम, ये टाइम के साथ कुछ चेंजेस अकर हो रहे हैं, तो उन चेंजेस को अगर देखना चाहते हैं तो हमें मॉडर्न वो एबिलिटी होनी चाहिए कि वो टाइम
मेमोरी
learning.
पूरी बनाने के लिए एएनएन लगता होगा।
ये क्लास ऑफ एन है
that is also
एन
that is type of writing,
सारा डेटा फीड कर दोगे।
not
No,
type of
that's
it.
not.
time is involved.
टाइम
The first line was the NN model is inspired from our brain.
Hmm.
We believe that our brain has memory. Then NN could also have memory, and this NN has no memory, right? So NN with memory will be a better solution, and that is RNN. RNN is a class of NN that has memory, and this NN, whatever we discussed here, is with no memory.
मेमोरी तो डेटा से ही बनेगी ना।
नहीं memory. I mean memory will this
जैसे डेटा देखे देखे राइट, जैसे अब मैं बोलूँ मैं कौन हूँ, तो अभी आप मुझे अभी देख रहे हैं अभी बता रहे हैं राइट, अब मेरे यहाँ पे बहुत वीडियो है, जैसे वीडियो सीक्वेंस ऑफ इमेजेस, बहुत सारी इमेजेस हैं वीडियोस में, है ना, तो वो इमेजेस का एक सीक्वेंस है, इसी तरह डेटा भी तो आ रहा है, टाइम सा आ रहा है, तो जो मेमोरी है उसमें डेफिनेटली नहीं, तो देखो बिना विदाउट मेमोरी कुछ नहीं पास करते
RMN. So suppose if I install the software, then I see sitting that this particular patient has died, while RN predicting that patient will die after 5 years. So it will also improve itself with time.
नहीं, that is
memory is also a set of neurons which which collects the information, current information as
And
well as the
previous.
past information.
हाँ पास
There are
if there is a
set of
dependency between previous and present information, then we should use RN.
This is what I'm trying to suggest.
I am two basic things.
Please.
Firstly, from where these parameters came, that we could call plethora of we
Parameters.
call it language independent variables. So from where the independent variables came, number one. Number two, how different AI models, I can do prediction based on pure classical statistics also.
Correct.
Then why there is of AI based modeling? I can make an online score calculator and it can complete it.
That is what I pointed
You
out.
can
Why there is AI based model? Number second. Now I don't know from where those parameters could be included in this. Now one way to look at that is because I'm not sure how AI works, but for classical statistics, I know how it works. So maybe they must have done a universal analysis of all the independent variables, and wherever there is an association found, we have taken all those independent variables, put in a multivariate analysis to remove the interdependency of the variables. If we look at the beta coefficient, what is the weight of each independent? And according to that weight, with each independent variable like HPV status or TNM carries, you assign a score. Suppose beta coefficient is 8, 0.8. So you assign 8. Then you add total score. So suppose total score has come 15. Now you want to say what cutoff. Suppose some patient gets score 9. That 9 score, how this model is working, what should I take cutoff? Positive or negative? You have to differentiate, low risk and high risk. So at what cutoff, then you do your house, so that you divide in. We can do simple statistics. Why there is no way?
इनकी ना स्लाइड है जिसमें आप वही में डिस्कशन के जस्ट पहले वाली स्लाइड जिसमें उन्होंने तीनों को कंपेयर किया है, एक है एक्सपी बूस्ट और मल्टी वेरिएबल एनालिसिस। तो 0.68 फॉर ANN, 57 फॉर XP बूस्ट, 0.65 फॉर मल्टी वेरिएबल। यही बोल रहे हो ना आप, AI क्यों चाहिए जब इसमें सबका AUC मतलब बेसिकली XP बूस्ट का खराब AUC है, बाकी सबका तो अच्छा ही है।
शॉर्ट टाइम कवरिंग के लिए
And another advantage which
टाइम सेविंग,
Yeah, yeah, correct.
मेनली टाइम सेविंग।
correct, it's not possible.
Definitely.
जैसे एग्रीकल्चर में आते हैं ना, ऑल दीज आर बेस्ड ऑन स्टैटिस्टिक्स। So you put just IPI scoring, MTSR, IPI, RSS, staging, okay, in some way it
to be made. One of the जो हमारा डिस्कशन है कि जैसे प्रिडिक्ट बनता है, MD कैल बनता है, या वैसा ही हम क्लिनिकल पैरामीटर सो इजीली अवेलेबल।
That will be machine learning ना, मतलब it is feeded with a certain data set. It is a machine learning. It will give a straight, मतलब it won't reform the data by its own. That artificial intelligence. So that is, this is machine learning that will go that we have given the data, it transformed and the output come. Yeah,
कट ऑफ का
but that's a machine learning. But artificial intelligence, according to me, it is like when we provide the data, it takes previous data and make some hyperparameter combinations with them to give the best predictable outcome. That is artificial intelligence, where that the own model use its memory from previous and the current data set to make a better outcome, not just straight linear machine learning outcome. It will transform by its own, just like our human brain do.
हाँ मतलब हम इसको दो तरीके से देख लें कि हमने उसको एक डेटा दे दिया, तो हमें रिस्क स्ट्रैटिफिकेशन करके दे दिया
Yes,
उसने।
ma'am.
अब वो विद टाइम हम जैसे जैसे उसको डेटा देते जा रहे हैं वो और इम्प्रूव होता जा रहा है, और वो आपको उससे एक्स्ट्रा सजेशंस भी दे रहा है।
Yes.
ये फिर आपकी सेकंड फेज जो मुझे लगता है सेकंड फेज।
Yes, the weight plasticity is there.
The whole advantage of AI is it will learn the rules to categorize or the data by itself. You will not have to hard code anything. Ki if this comes, if there is certain change in the data, we have to again change the rule. So the AI model will automatically adapt to those changes. So we do not have to like explicitly.
One thing, let me clarify something, some threshold, this high, this value, how to decide. In NL, we don't decide any threshold, right? Based on the optimal criteria, we need to estimate something. We have a loss function, cross and drop loss, where we have the ground truth and the output predicted by the model. We basically minimize the cost. So we have some basic cost that we minimize using the cross and drop loss. And the parameters that will give you the minimum cost is your model, the set of parameters. So we don't have any threshold in case of AI. We don't have any threshold.
तो अगर थ्रेशोल्ड बनाना हो तो फिर
For that,
That will not be a good model because every time you have to change the model.
thresholds usually we can decide. Like जैसे कोई classification problem है, ultimately अगर कोई single neuron है, binary classification कर रहे हैं and sigmoid activation है, then you will have the output in the range 0 to 1. Then in order to categorize किसी class में, you will have to set a threshold. And usually what we do, we usually compute that AUPR score, and the threshold which gives the best AUPR score, we set that threshold during the inference only, but not at the training time. Training time, there is no need of threshold.
जैसे इन्होंने भी थ्रेशोल्ड बनाया है 0.6 समथिंग ऐसे कट ऑफ सी।
हाँ, वो during inference it's needed.
Therefore, actually training with while training the model, so we need to prepare the training data set, right? So training data set, who prepare training data? With doctors actually prepare. Because this person belongs to this class, who will tell? I cannot say.
I guess you are getting confused with the statistical analysis not in the learning. Statistical analysis always have this threshold. Statistical analysis work only on this. You have some data, so let's say low risk है, some data high risk, और उसके बीच में you are just going to put a line somehow, है ना, वो कुछ भी हो रहा है, whatever the basis, 0.5 है, इसके इधर सारे low हैं, इसके इधर सारे high हैं, पर ANN में ऐसा नहीं है। ANN में actually threshold आप बोल रहे हैं ना, it's a non-linear line,
बस कंटिन्यूअस चल रहा है ना, लाइन कंटिन्यूअस है। आपको
Line से चाहिए।
जैसे मतलब मैं इसको बताऊं, इस स्टडी में अगर में इन्होंने सी इंडेक्स कैसे किया?
yes, yes, If the data is non-linear, then statistical analysis is best. If the data is non-linear, it's already many parameters which are non-linear. I am not overall logistic regulator. Yes, we can. If you are sure that it is non-linear, you cannot be sure until you are applying. Non-linearity is something. Simple to this now. Let's say हमने basic maths पढ़ लिया x1 plus x2 plus x3. ठीक है, this is a non-linear. This is a linear x1 plus x2 plus x3. But if you have a relation like x1 square plus x1 x2 plus x3 cube, this is a non-linear relation. Now अगर इस डेटा पे आप लगाओगे मल्टी वेरिएबल एनालिसिस, इट इज नॉट लिनियर.
देखो मैं ये कहना चाह रही हूँ कि थ्रेशोल्ड तो क्लिनिशियन डिसाइड करेगा ना. जैसे हमने क्या किया कि जब वो 15 सेंटर का डेटा आ रहा था, उससे स्कोर कैलकुलेट हो रहा था. हमने देखा कि जिनका वो कौन लोग हैं जो 2 साल से पहले मर गए. अब वो जो 2 साल से पहले मर गए उसको हमने हाई रिस्क बोल दिया, और उनका मेरे ख्याल से जो भी स्टैटिस्टिक्स से स्कोर आ रहा था, हमने एक्सेप्ट किया कि 2 साल की मोर्टेलिटी हम एक्सेप्ट कर रहे हैं कि अगर वो 2 साल से ज्यादा जी गया तो अच्छा जी गया. अब विद बेटर ट्रीटमेंट हो सकता है हम आगे चल के ऑप्टिमिस्टिक हो जाए, 5 इयर्स का कट ऑफ रखिए.
वो कर सकते हैं. अच्छा,
उन्होंने भी तो ऐसे किया ना, 2 इयर्स पे उन्होंने मोर्टेलिटी देखी.
तो ऐसे कंक्लूड कर सकते हैं. I use an example. About 100 years back, when treatment of carcinoma breast started, it was lumpectomy. People they found that there are more recurrence after doing lumpectomy. So they increased the level of surgery. Then came lumpectomy with bides. Again, there were a lot of mortalities. So finally, they decided radical hysterectomy, holistic, 100 years back. When they were removing the breast, overlying skin, underlying muscles. Then was also not full treatment. So further extended to extended radical method, where they were removing in the ribs, supraclavicular limb, everything was, but still survival was at some level. Then there came changes, further development of the radiotherapy techniques. So they reduced the extent of the surgery. Came modified radical mastectomy PDs, where they were not removing the whole overlying skin, not removing the muscles, only the breast and lymph nodes. Then further came chemotherapy. So this modified radical mastectomy again came back to the lumpectomy. So now the latest treatment is the breast conservative surgery, where they do lumpectomy, radiotherapy, and chemotherapy. So as advancement in the treatment part happens, advancement in the diagnostic facilities happens, we change. Similarly, if suppose this is a basic study, and now if you all expert of the AI field, that we can do something better than this by incorporating some other new research models, then we should think of that. The idea of including new scientists today in this forum is that whether we can do in this institution, because we have a lot of cases of the head and neck cancer or other cancers, a study where incorporating AI may give us good information about the diagnosis and about the prognosis and the planning. Definitely. So let us sit together and do something for that. But I am telling you that same thing I am discussing with your institution for last 7 years. I have so many meetings with your director when Dr. Desmukh was there, and previous director also, and others also. So I think let us do and start something good. Great. Last time we meeting with Dr. Bhagwa or some of we have a lot of, you see, when she spoke to us in this direction. And these studies are coming from the different institutions of important that I cancer.
क्योंकि क्या है, आप लोग तो हमें तब मिलोगे मतलब एटलीस्ट वी शुड डिसाइड कि हमें 3 चीजें तो करनी है। नंबर 1, इन्होंने जो अब आपकी वो वाली लाइन थी ना कि कौन-कौन से क्लिनिकल पैरामीटर्स इंक्लूड नहीं हुए डिस्कशन में। हम ये जो इन्होंने पैरामीटर्स इंक्लूड किए हैं, प्लस जो इन्होंने बोला कि हम नहीं इंक्लूड कर पाए आगे वाले में, वो जिसमें टीएलसी और
Yeah.
टीएलसी,
Listener.
एल्बुमिन, ये सारे पैरामीटर्स हम आपको दे दें और आप उसमें से आइडेंटिफाई कर लो कि कौन सा सबसे इम्पोर्टेंट रहा। और वो जो कैलकुलेटर बनाने की बात हो रही, आई थिंक दैट इज द इजीएस्ट। एक्चुअली क्या होता है, अब हम नेक्स्ट टाइम हम ऑन्कोटाइप की क्लास रखेंगे, हम उसमें भी आपको इनवाइट करेंगे। वो तो ऑन्कोटाइप में उन्होंने क्या किया कि सबसे पहले एक जैसे क्लिनिकल कैलकुलेटर अवेलेबल था जिससे हमें पता रहता था कीमो देनी है कि नहीं देनी। फिर जेनेटिक टेस्ट आ गया जिससे हमें पता चलता है देनी है कि नहीं। अब उस जेनेटिक टेस्ट में वो क्लिनिकल पैरामीटर्स एक्स्ट्रा ऐड कर रहे हैं, तो क्लिनिकल प्लस जीनोमिक टेस्टिंग। हम भी 3 फेज में चले। सबसे पहले क्लिनिकल पैरामीटर्स जिसका डेटा हमारे पास अवेलेबल है, हम उसमें कोई पैसे खर्च नहीं करने। अगर हम उससे कैलकुलेटर जनरेट कर सकते हैं, नेक्स्ट हम उसमें पैथोलॉजी की आई थिंक हमें इमेजेस डालें कि कोई भी सर्जिकल स्पेसिमेन का जो 10 मोस्ट अग्रेसिव स्लाइड्स है पेशेंट की, वो हम आपको पास आउट करें, मॉडल्स को स्टडी करें, उस हिसाब से वो बताए कि वो हम देख लें कि इस मॉडल में कौन कौन 1 साल पे मर रहा है या रेकर हो रहा है, तो हाई रिस्क लो रिस्क हो जाएगा। और फिर बाद में रेडियोलॉजी भी ऐड कर सकते हैं उसमें।
See this paper maybe more instead paper over this topic, same topic. Maybe I don't know. This paper is very worth the press.
So it was published in
लास्ट
it was published in no,
ये पब्लिकेशन में ना होगा 1 साल में, उसके जो रिव्यूज और वो सब होने होंगे। So we are never going to undermine anyone's research. This is a thought-provoking mistake. We build on what we have and what we can do better. हम कोशिश करेंगे कि हम इसका अभी रिसेंट हुआ ना तो हम सप्लीमेंट्री एक्सेस नहीं कर पा रहे, थोड़े टाइम के बाद हम श्योर वी विल बी एबल टू एक्सेस। थोड़ा एक तो पुराना हो जाए 1-2 महीने। समाउ साइन अप बैन हो गई है इंडिया में, खुल नहीं रहा है तो डेटा एक्सेस नहीं हो रहा है उसको। Sire is not getting open, so we tried opening it.
रिसेंट वाले तो डेफिनेटली नहीं हो सकता। आई थिंक 2024 2025 वाला पेपर स्कूल से ही नहीं।
We can also dig कि अगर इससे related पुराना कुछ हो।
तो हमारे इंस्टीट्यूट के नेटवर्क में कोई पब्लिकेशन एक्सेसिबल होती है।
Correct. We can next day basis, next week studying the code identity, and then start working. So we are thankful to all 3 of you that you have come and given valuable time.
Same.
And again, congratulations to the project. You have finished very well. So if you it's okay, we can continue.
Thank you.
Because I just wanted to know how this code is.
an article with the PPT code.
So article means best for me because I thought it would go using on the then example. So that okay. The comment was take on for the gen. It is how tumor control probability and not complete probability. How you match it and how the tumor get resistance and sensitivity for radiation. So
I'm Dr. Bhagat Singh. I have a paper publication. So I am really academic. So it is where you sit there.
Send the 104 only, OPD. 104.
10, okay. What's your good name, sir?
Dr. Devan.
Devanshu.
Yes.
Okay. Because I will give you the project also, and not only do presentation also I have prepared it that one. So only thing is that I can't hear no, so because of situation,
No, I will provide you with a whole of original article and the presentation.
Enough for me because I can regulations and other thing how they did it, optimization how they did it is not given in that one. So that and secondly, score related to the probability artificial. What artificial intelligence is give probability.
Yes, sir.
It's up to 0.99.
Yes, sir.
It gives it is not a perfect. It's not perfect.
Now, sir, we are going to know that the outcome of the artificial intelligence should be taken by the doctors and not healthcare individuals should take on it.
Now I work at that one. The patient which is treating it. Tumor microenvironment, the changes in
It is changing.
lot of changes are there. I have written it all the things which is changing. One only thing is that one. I wanted to because proton dynamic also there.
Good morning, everyone. Today's topic of Journal Club is 10-year survival after post-mastectomy chest wall irradiation in breast cancer, that is Supremo trial, published in November 6, 2025 in New England Journal of Medicine. The background, mastectomy is standard care for more than one-third of patients with stage 1 and stage 2 breast cancer. Stage 2 disease involves tumor no more than 5 centimeter in diameter with metastasis in 1 to 3 axillary lymph node, that is N1, tumor of at least 2 centimeter without nodal metastasis. The stages is T1 N1 M0, T2 N1 M0, T2 N0 M0 and T3 N0 M0 in the TNM system. Tumor size T1 less than 2 centimeter, T2 more than 2 centimeter to 5 centimeter or T3 more than 5 centimeter. Patient with stage 2 breast cancer who have N1 disease or who have N0 disease but with poor histological feature, including large tumor size, a histological grade of 3 or lymphovascular invasion are considered to be at intermediate risk for recurrence. Landmark Danish and Canadian randomized controlled trial reported in 1997 and 1999 showed that post-mastectomy radiotherapy for stage 2 and 3 reduced the risk of locoregional recurrence and improved 10-year survival among women with nodal metastasis. A 2014 meta-analysis of trial of post-mastectomy radiotherapy by the Early Breast Cancer Trialist Collaborative Group, which included data from the Danish and Canadian trials, showed that among patients with disease classified pathologically as N1, the cumulative incidence of locoregional recurrence as a first event at 10 years was 16.5 percentage point lower with post-mastectomy radiotherapy than with no post-mastectomy radiotherapy and 20-year survival was 7.9 percentage point higher. The adjuvant systemic therapy used in these trials is now considered to be suboptimal. The rationale for Supremo, a major improvement in systemic therapy and reduction in breast cancer mortality, have challenged the applicability of the evidence base for post-mastectomy radiotherapy in current practice. The trial objectives are to evaluate the omission of chest wall irradiation in women with intermediate risk breast cancer treated with mastectomy and contemporary adjuvant systemic therapy. Evaluation of post-mastectomy radiotherapy in patients with one or three involved nodes become a research priority of the National Institute of Health in 2000. Supremo, that is selective use of post-operative radiotherapy after post-mastectomy trial, which present a more contemporary picture of the effect on overall survival of post-mastectomy radiotherapy selectively delivered to the chest wall. Study design, this is an international phase 3 randomized clinical trial at 125 sites in United Kingdom, 25 sites in 7 countries in continental Europe, and 1 site in Israel and Turkey, overseen by the EORTC and thereafter referred to collectively as EORTC sites, and an additional 21 international sites. Randomization, patients were randomly assigned in a 1:1 ratio to undergo chest wall irradiation, the irradiation group, or not to undergo chest wall irradiation, the no irradiation group, with the use of permuted blocks with varied block size to minimize the effect of entry bias. Randomization was stratified according to the treating center. The protocol specified guideline for pathologically analysis, surgery, radiotherapy, and adjuvant systemic therapy. The pathology report for all patients in the trial were reviewed to check eligibility. This is a large cohort, 1607 patients included in the intention to treat population. The criteria for patient, all patient who are undergone a mastectomy for stage 2, intermediate risk cancer in one patient without distant metastasis, had a minimal clear margin of 1 mm. Patient undergoing intermediate breast reconstruction were eligible if they met the other criteria for inclusion. According to protocol as amended in 2010, patients were also eligible with stage 2 breast cancer classified as pathologically T3 and 0. Patients who had received neoadjuvant chemotherapy were eligible to participate. Treatment and radiotherapy intervention. Patient assigned to radiation group received doses ranging from 40 gray in 15 fraction to 50 gray in 25 fraction. The clinical target volume encompassed the chest wall, skin flaps, and soft tissue from 5 mm under the skin surface down to the deep fascia. Quality assurance for radiotherapy was performed at the institute level and at the patient level. Systemic therapy, adjuvant or neoadjuvant chemotherapy with anthracycline containing regime with or without taxane were recommended. Trastuzumab was administered according to the local policy. A minimum of 5 years of adjuvant endocrine therapy was recommended for patients with ER positive tumor. Tamoxifen and aromatase inhibitor or a sequential combination was advised for postmenopausal patients and for premenopausal women. Tamoxifen, ovarian ablation, or both were recommended. Follow-up in the first year for assessment of acute side effect. Follow-up took place at the end of the course of radiotherapy for patient who has received radiotherapy. 3 months after chemotherapy for patient who had received chemotherapy but not radiotherapy. 3 months after the date of mastectomy or the date of final definitive surgery for patient who had not received radiotherapy or chemotherapy. All the patients were seen annually from the date of mastectomy for 10 years. Contralateral mammography, if appropriate, was recommended every 2 years for 10 years. Follow-up from the recorded disease status, any active treatment, and side effect were completed at each visit. Side effect of treatment were assessed with the EORTC radiation therapy oncology group radiation morbidity scale. Endpoint of this trial, primary endpoint, overall survival assessed at 10 years, and secondary endpoints are chest wall recurrence with or without recurrence elsewhere, regional recurrence, disease-free survival, distance metastasis-free survival, cause of death, short-term and long-term radiation-related adverse event, quality of life, and cost effectiveness. The statistical analysis, the null hypothesis was that chest wall irradiation has no effect on overall survival among women with intermediate risk breast cancer treated with mastectomy, axillary surgery, and adjuvant systemic therapy. So initial original sample was 3500. This is a superiority design, power 80% and significance was 5%. So they reduced the sample size due to slow accrual and extended follow-up to 10 years and widened eligibility criteria to exclude patients who had received systemic chemotherapy. So revised sample size with 1607 with 609 patient endpoint after 5% loss to follow-up. Provide the trial 80% power and 5% significance. Patient to detect 7% difference. Assume 10-year overall survival of 63% in irradiation group versus 56% in no irradiation group. Analysis type intention to treat. Cox proportional hazard model adjusted for reason. Kaplan-Meier calculation and plots were used for graphic display and estimation of endpoint value at 10 years. Subgroup analysis performed with stratum specific estimate and confidence interval. Result between patient between August 4, 2006 and April 29, 2013, a total of 1679 patients underwent randomization. The intention to treat population included 808 patients in the irradiation group and 799 in the no irradiation group. The median follow-up was 9.6 years. The trial was locked at June 19, 2024. So this is a concert flow diagram which is so randomization and follow-up. So in 1691 patient are they took and 12 patients were not eligible due to these following criteria, and now 1679 underwent randomization, 845 underwent chest wall irradiation, and in that 37 were excluded, and final patient were 808 were included in the intention to treat in the irradiation group, and 799 were included in no irradiation group. This table show the demographic and clinical characteristic of patient. So most of the patient came from the United Kingdom. 582 in chest irradiation. I will note it in CWI and no CWI. So 582 in chest wall irradiation group, CI group, and 586 in no CI group. Continental Europe 165 in CI group and 158 in no CI group. And other location from other locations 61 and 55. Age median age was 54 in CI group and 55 in no CI group. And age by distribution less than 45 year, 130 in CI group and 121 in non-CI group. And most of the in 45 to 54 and 55 to 69 almost similar, 285 and 283 in CI group, and 267 and 309 in non-CI group. Pathological invasive type, ductal carcinoma are more common, 672 in CI group and no CI group, 669 patient. Histological group, most of the patient are grade 3, 416 and 421. Molecular subtype, ER positive and ER2 negative, or ER positive and HER2 status unknown, 517 in CI group and 520 in no CI group. ER positive and ER HER2 positive, 1110 and 95. ER negative and HER2 positive, 61 and 62. Triple negative patient are 91 in CI group and 84 in non-CI group, no CI group. Breast cancer stages, T1N1, 241 in CI group and 226 in no CI group, T2N0, 183 and 205, and T2N1 are the more common, 368 and 361 in following group. Median number of nodes examined, 14 in CI group and 14 in, these are common in both the group. Total number of nodes involved, N0, 191 in CI group and 211 in no CI group. Is 1 lymph node, 330 and 312. 2 lymph nodes positive in 195 and 171, and 3 lymph nodes, 89 and 104 patients. Axillary surgery, sentinel lymph nodes biopsy only in 115 patient in CI group and 118 patient in no CI group. Clearance only 393 and 349. Sentinel node biopsy or sampling plus clearance 239 in CI group and 245 in no CI group. Sampling only done in 31 and 40 patient. Immediate breast reconstruction done in 95 patient in CI group and 80 patient in no CI group. Chemotherapy received 696 patient in CI group and 666 patient in no CI group. Endocrine therapy received 640 in CI group and 624 in no CI group. Treatment with trastuzumab 168 in CI group and 115 no CI group. Prescribed radiotherapy dose for chest wall 40 gray in 15 fraction or 43 in 16 fraction is 444 in CI group and 1 in no CI group, and 50 gray in 25, 230 and 6 patient. Others are 101 and 3. So the result continue. Irradiation of the supraclavicular fossa was performed in 97 patient in the irradiation group and 12 patient in the no irradiation group. Irradiation of the internal mammary chain was performed in the 12 patient and 7 patient respectively. Overall, 84.8% of patient received chemotherapy, which was delivered according to the local protocol in 87.4% of cases. 78.7 received endocrine therapy and 19.8 received trastuzumab. So this slide show overall survival. So there is no statistically significance difference in overall survival. Chest wall irradiation group, the 81.4% patient in 10-year overall survival, 808 patient received chest wall irradiation, and in other group 81.9% patient. So these are the similar. Hazard ratio is 1.04, near parity between the two arms, and 95 confidence interval 0.822 to 1.30. So this is a Kaplan-Meier curve showing the overall survival. In chest wall, 150 patient out of 808 died after 10 years, and no chest wall irradiation 145 and 799 patient. So this is the percentages both in similar both the group. So there is no overall survival. Cause of death, total death were 295, and breast cancer, cause of death from the breast cancer, so 194 patient, that is 65.8%, and other causes 34.2%. Secondary endpoints are chest wall recurrence, 9 patient in irradiation group and 20 patient in no irradiation group. Hazard ratio is 0.45 with confidence interval 0.24 to 86. So it is shown that RT significantly reduced local recurrence, but the absolute difference was less than 2%. In loco-regional recurrence, 22 patients in CI group and 36 patients in non-irradiation group. Hazard ratio is 0.61 and confidence interval 0.36 to 1.03. Reduction did not reach statistically significance, and distance metastasis-free survival, that is 78.2% patient in irradiation group and 79.2% patient in no CI group. Hazard ratio is 1.06, confidence interval 0.86 to 1.31. No benefit observed for distance control. Disease-free survival 76.2% and 75.5%. So it is also shown that overall disease control was equivalent between group. These are the Kaplan-Meier curve for secondary endpoint. First one is chest wall, showing the chest wall irradiation. So in chest wall irradiation group, 9 patient out of 808 and 20 patient from 799 in no chest wall irradiation group. So it's showing the chest wall irradiation group is slightly benefit, but the benefit is less than 2%. The other groups showing no significant benefit. A distance metastasis or death occur in 176 patients, 21.8% in the irradiation group and 166 in the no irradiation group. Breast cancer recurrence or death occurred in 192 patients in the irradiation group and 196 in the no irradiation group. Nodal status PN0, high risk nodal negative patients showed no survival benefit from irradiation. Death rate 23.6% in RT group versus 19.9% in no RT group. N1 patient also show no survival benefit. The death rate was 16.9% in RT group versus 17.5% in no RT group. This study examined various clinico-pathological factors to identify any subset of patients who might benefit from chest wall irradiation. So factors include nodal status, tumor size, histological grade, and receptor status, ER, PR status, HER2 status, or triple negative. So this study showed the triple negative group. This is the only subgroup that showed a potential harm was patient with triple negative disease. Higher mortality, TNBC patient receiving irradiation had an increased risk of death. Hazard ratio of death 1.91, 95 confidence interval 1.06 to 3.46. This was an exploratory finding from a small cohort of the TNBC patient and must be interpreted with caution. So this is a forest plot of subgroup analysis of overall survival. The overall survival showing no significant difference. As per age group, less than 45 year show a slightly benefit but statistically not significant, and these two group 45 to 54 and 55 to 69 also show no significant benefit. More than 70-year patient, the older age patient, the confidence interval is less than 1, so it is also so slightly benefit, but it is not that much. Nodal status N0, the hazard ratio is 1.21, so this is also it is also showing no benefit, and in N1 group it is also almost identical. There is no statistically significant. And molecular subtype, the ER HER2 negative, ER HER2 positive, and ER HER2 positive. This is also showing no significant benefit, but in triple negative group, in no CI group, that is show that is causing harm to the patient, and no CI group was better. Safety, toxic effect of radiotherapy were mild. The incidence of lung-related adverse event of grade 2 or higher was less than 2% overall. So 13 lung-related adverse event of grade 2 or higher occurred in the irradiation group as compared with the 5 in the no irradiation group. Death from lung cancer occurred in 7 of 80 patient and in 7 of 799 patient respectively. Cardiac event, death from cardiac cause occurred in 6 of 808 patient in the irradiation and in 8 of 799 in no irradiation group. Bone related event, no significant difference. So now come to the discussion. They found no evidence of any effect of irradiation on overall survival, disease-free survival, or distance metastasis-free survival among patients with intermediate risk breast cancer, and irradiation had minimal effect on the incidence of chest wall recurrence over a 10-year period, a between group difference of less than 2 percentage points. They estimated that adjuvant radiation would prevent a sufficient number of chest wall recurrence, so to show a clear benefit for overall survival at 10 years. Projected a between group difference of 7 percentage point for a hazard ratio of 1.255 under the assumption that survival with no chest wall irradiation would be 56%. But however, they found 10-year survival to be approximately 81% in both groups, and the cumulative incidence of local recurrence was low. The trial result must therefore be interpreted in that context. The 95 confidence interval for the hazard ratio of primary endpoint 0.82 to 1.30 is compatible with an absolute difference in overall survival of up to 3.8 percentage point. Although the prescribed hazard ratio of 1.255 is contained within the confidence interval, the interval represents a far small absolute change relative to the observed survival that was originally estimated. They consider that the original calculation of the power of the trial is no longer informative because breast cancer mortality has fallen considerably since the trial started. Consequently, they consider that the trial provides robust data on the effect of radiotherapy despite the lower than expected number of events owing to improved survival. Although cannot rule out small positive or negative effect on overall survival, it is biologically implausible that an absolute difference in chest wall recurrence of less than 2 percentage point would translate into a meaningful survival benefit. So this data is how this data is different from previous meta-analysis. So EBCTC 2014, this included older trial 1970 to 19, less effective. They use less effective chemotherapy, no trastuzumab use, high baseline recurrent trial, and the Supremo used modern chemotherapy, targeted therapy, better endocrine therapy, and low recurrence rate. So this result contrasts with those of EBCTC overview of trial that preceded modern testing of ER and HER2 status, in which radiation was associated with a lower cumulative incidence of local regional recurrence as a first event, then no irradiation at 10 years. Lower cumulative incidence of any first recurrence at 10 years, 34.2% versus 45.7%. Lower breast cancer mortality at 20%, 42.3% versus 52.2% among 1314 patients with N1. This trial included a similar number of patients with N1 disease, 1201 patient. A likely explanation for the contrast in the finding from the EBCTC meta-analysis and our trial is higher breast cancer survival owing to advance in multidisciplinary management, especially in the area of diagnostic and systemic therapy. This data challenge the concept that chest wall irradiation should remain a central tenet of locoregional post-mastectomy radiotherapy. This data fit with the hypothesis that the survival benefit from local therapy increase with more effective systemic therapy, but only to a threshold beyond which the benefit declines, suggested that contemporary systemic therapy has reached this threshold, and therefore we are observing a decline in benefit from chest wall irradiation. And adherence to systemic therapy guideline was high. The radiotherapy quality assurance program and the observed between group difference in chest wall recurrence, albeit a clinically insignificant absolute difference of 11 patients in 10 years, provide a reassurance that the lack of effect of chest wall irradiation on overall survival is unlikely to be due to inadequate radiotherapy. They believe the pragmatic guideline for pathological analysis and treatment among trial participants who were widely spread across international locations reflect real-world experience and underpin the generalizability of the finding. Since the recruitment period for the trial, advances in systemic therapy have further improved survival, which strengthen the rationale for omitting chest wall irradiation for patients with intermediate risk. Chest wall recurrence was rare in this trial. The cumulative incidence over 10 years was less than 3% with no irradiation, much lower than the 5 to 15% estimated for intermediate risk disease at the time the trial was designed. Other studies have also shown a similar low incidence of local recurrence, with modern therapy that incorporates multiple treatment approaches. The cumulative incidence of local recurrence at 5 years in National Surgical Adjuvant Breast and Bowel Project, NSABP 551 RTOG 1304 trial, which also recruited patients with 1 to 3 cancer positive nodes, was less than 1 among patients who did not undergo irradiation. This incidence is similar to this trial at 5 years. If very few patients have locoregional recurrence at a first event without radiotherapy, chest wall irradiation is unlikely to reduce mortality. The apparent lack of effect of omission of chest wall irradiation on disease-free survival and distant metastasis-free survival is reassuring. Chest wall irradiation did not appear to have a differential effect on overall survival among patients with PN0 or PN1 disease. The 10-year overall survival among patients who had PN0 tumor with other risk factor was similar to those among patients with PN0 tumor, PN1 tumor, which justify the inclusion of patients with intermediate risk PN0 disease. They confirmed that the histological grade of 3 lymphovascular invasion and large tumor size are associated with a level of risk that is similar to that associated with the N1 disease. Subgroup analysis according to molecular subtype suggested a worse outcome with radiotherapy than with no radiotherapy for patients with triple negative cancer. This finding could be due to low number of patients with triple negative breast cancer, but inconsistent with the data from the NSABP V55 RTOG trial, which showed a hazard ratio of 2.30 and 95 confidence interval 1 to 5.25 for invasive breast cancer recurrence among patients with triple negative breast cancer who underwent irradiation as compared with those who did not. Subgroup analysis according to molecular subtype suggested a worse outcome with radiotherapy than with no radiotherapy for patients with triple negative. They speculated that this negative effect of radiotherapy among patients with triple negative breast cancer might be due to a detrimental effect of radiation on immune modulation. They recognized the recent shift from axillary node clearance to regional nodal irradiation as primary treatment. The EBC TCG overview of trial showed that regional nodal irradiation was associated with the modestly lower breast cancer mortality than no regional nodal irradiation among patients with N1 disease, whereas this trial showed no evidence of survival benefit from chest wall irradiation as a component of post-mastectomy radiotherapy. The limitation of this trial, the trial was initiated nearly 2 decades ago. There have been many improvements in practice since then, which have led to a lower incidence of local recurrence. Second, many patients with intermediate risk are now treated with neoadjuvant systemic therapy, but this practice was very limited in this trial. The EBCTC meta-analysis showed no difference in survival between patients treated with adjuvant therapy and those treated with neoadjuvant chemotherapy. The NSABP trial included patients with clinical N1 disease who were pathologically node negative after neoadjuvant chemotherapy. Post-mastectomy radiotherapy had no effect on the invasive breast cancer recurrence-free interval among the patients who had undergone mastectomy. And invasive breast cancer-free survival at 5 years among the patients who had undergone mastectomy was approximately 90%, which was similar to the survival in this trial at the same point in time. The third limitation is considerable reduction in axillary surgery has become standard practice. In this trial, axillary node clearance was mandatory for N1 disease. Since the beginning of the trial, it has become apparent that no particular axillary node staging procedure influences overall survival in early breast cancer. Axillary node clearance has been replaced by alternative approach such as sentinel node biopsy, axillary irradiation, or the omission of the further treatment, which may be an option for patients, including those treated with neoadjuvant chemotherapy. Finally, the importance of identifying the number of pathologically involved axillary node is predicting prognosis in evolving and being superseded by an approach that incorporated multiple factors, including a combination of tumor characteristic, auxiliary imaging, and gene expressing profile to predict the reason of recurrence and death from breast cancer. The Taylor RT regional radiotherapy in biomarker low risk node positive and T3 and 0 breast cancer trial is using gene expressing profiling with oncotype DX in N1, ER positive and HER2 negative disease to tailor indication for adjuvant locoregional radiotherapy. The Trans Supremo trial tissue archive is available for investigation of prognostic and predictive biomarkers. Benefit of chest wall omission: the low level of toxic events such as radiation pneumonitis in this trial, as well as the low incidence of death from cardiac causes, probably reflect the application of modern radiotherapy technique. They were aware that irradiation-induced cardiac disease and carcinogenesis can manifest more than 10 years after. If chest wall irradiation is no longer required in women with intermediate risk, these and other late onset effects, including fibrosis, bone necrosis, and muscle and skin atrophy, could be avoided. This result have implication for breast reconstruction in context in which its use is controversial. Some surgeons consider post-mastectomy radiotherapy to be a relative contraindication to immediate and implant-based reconstruction because radiation increases the risk of complication and is associated with the poor prognosis. So these trial findings are likely to reassure surgeon whose patient wish to undergo breast reconstruction, especially in situation in which implant are used. This result stimulate a re-evaluation of the evidence base for indication for chest wall irradiation, continuing to recommend chest wall irradiation in context in which evidence of benefit is marginal and the procedure is potentially detrimental, may divert limited resources from more effective treatment. So the conclusion, chest wall irradiation did not result in higher overall survival than no irradiation among patients with intermediate early breast cancer treated with mastectomy and contemporary adjuvant systemic therapies.
Excellent paper selected for getting the text. It's open for the discussions and comment.
इसमें जिन लोगों को लोकल रेजिडेंट हुआ होगा उसमें से 100% ने ट्रीटमेंट रिसीव किया होगा ना, बिकॉज दे वर अंडर ट्रायल. तो हमारे का केस होते हैं तो पेशेंट में नॉट नेसेसरी कम फॉर फॉलो अप. और उसका जब तक हमारी प्रॉब्लम तो यही है ना कि कंप्लायंस कितनी स्ट्रांग है फॉलो अप के लिए.
इनका पॉजिटिव पॉइंट था कि कंप्लायंस काफ़ी अच्छी है हमारे पास.
So can we afford that less than 2% chest wall recurrence in our setting?
इतने तो रेडिएशन देने के बाद भी हो ही जाते हैं. कुछ पेशेंटों में आ ही जाते हैं रिकरेंस, रेडिएशन के बाद भी आते हैं.
मतलब अगर हम इसमें ही देखें कि इनका ये कहना है कि टेस्ट वॉल रेजिडेंस लेस देन 2% ही रहा तो उसको एक्सेप्ट कर लो. लेकिन एक्सेप्ट तब करेंगे जब वो लेस देन 2% ट्रीट हो जाए. बाई चांस वो 5 साल के बाद डिफॉल्ट हो गया और उनको चेस्ट वॉल रेफरेंस हो गई, वो ट्रीटमेंट मिल गया, तो वो तो फिर पूरा सर्वाइवल को कॉम्प्रोमाइज कर देगा.
बट ये लोग बोल रहे हैं कि सर्वाइवल पे तो कोई इफेक्ट ही नहीं है चेस्ट वॉल रेडिएशन का. वो तो दोनों
फुल कॉम्प्लायंस है. और जितनी रेफरेंस हुई सारी रेफरेंस ट्रीट हुई. अपना पेशेंट को तो रेफरेंस तो आएगा ही. ट्रिपल नेगेटिव निकल के आएगी क्योंकि हम तो ट्रिपल नेगेटिव को अगर इंडिकेटर मानते हैं करना है.
फीमेल्स का भी इसमें जो है यंगर फीमेल्स
इसमें उल्टा ही निकल के आया कि चेस्ट वॉल इरेडिएशन दे रहे हैं तो ट्रिपल नेगेटिव वर्स उसमें सर्वाइवल और वर्स हो रहा है.
ट्रिपल नेगेटिव कभी भी सोल क्राइटेरिया नहीं है एडमिशन में लेना. ट्रिपल नेगेटिव हम बड़ा सोल क्राइटेरिया ये है बस. हाँ एक इंडिकेशन में लेके चलते हैं कि
एग्रेसिव है.
और इसमें ये भी है कि अगर हम अपनी सेटिंग में देखें तो लेस देन 45 इयर्स मतलब इनका जो मेजर एज वो 55 इयर्स है। हमारी मीडियम हो सकता है कम आए जैसे इंडिया में होता है कि यंग पेशेंट में होता है एंड लेस एज इज itself a risk factor for recurrence.
इसमें आपको लेस देन 45 में भी जो है
क्योंकि लेस देन 45 कम ही करते हैं
हाँ कम ही थे
130 and 125 भी कम है।
These are only 16% of the population. सिस्टमिक कीमोथेरेपी भी ऑन्कोटाइप भी लगा रहे हैं तो वो लेस देन 45 का अलग रिस्क स्ट्रैटिफिकेशन कर रहा है कि यंग मोर अग्रेसिव तो इसलिए ये उनकी चीज आ रही है फाइनेंशियल डॉक्टर और पेरेंट को 15 दिन रुकने में उसको दिक्कत तो बहुत होती है इसमें कुछ वो है एडमिनिस्ट्रेटिव पार्टी कुछ हो सकती है इसका प्लीज में मतलब जो इंटरमीडिएट रिस्क ग्रुप है हमने वो कि जैसे बाकी जो कोर्सेज होते हैं ना छोटे लेस देन नंबर ऑफ डेज वाले इसमें है कोई
इसमें है ना 5 डेज का है।
ये तो इन्होंने नहीं किया है
नहीं इसमें क्या मतलब ब्रेस्ट में अपन लोग 5 डेज का भी करते हैं ना 5 फास्ट है 25 डे इन 5 डेज में 5 ग्रे पर फ्रैक्शन में ऐसे करते हैं। नहीं पोस्ट में कोविड के टाइप का है।
काफी किया गया था
आफ्टर पोस्ट मैस्टेक्टमी है कुछ एग्रीगेटेड आरटी इन इंटरमीडिएट रिस्क उसकी क्राइटेरिया क्या है डॉक्टर अरोड़ा है हाँ उसकी क्राइटेरिया क्या है एडीपीआई पे कि किस कैंडिडेट में कर सकते हैं
एल्डर एज
मतलब it is
greater
not
than 50
low risk criteria. It is not intermediate risk.
क्वेश्चन क्या है रोज का व्हाट वाज द क्वेश्चन
Partial breast irradiation.
accelerated partial breast
Partial breast irradiation. Partial breast irradiation.
accelerated
Accelerated.
मतलब फुल फॉर्म क्या हुआ और उसमें आप डोज कितनी दोगे कितने दिनों में दोगे और फिर उसकी एलिजिबिलिटी क्राइटेरिया ठीक है
Now, after this paper, it's what are the indications for the advent radiotherapy in breast cancer?
And in lumpectomy, in modified radical mastectomy,
In lumpectomy, or is what is breast cancer?
breast cancer,
Lumpectomy. Lumpectomy we never do. Why it's
breast cancellation surgery, modified radical mastectomy में अगर ट्यूमर का साइज is more than 5 centimeter or more than 4 lymph nodes or close or nearest
more than 5 centimeter
I
and
think 5 centimeter. उसके बाद more than 4 lymph nodes, more or equal to 4 exit lymph nodes. Then
those criteria will go to this and category.
And group हो जाएगा 4 to 9 will be and then close or nearest
Here they have included and two also. Individually. Only and
they have included stage 2A and 2B. So they have included T1 and 1, T0 and 2.
T0
and also close and close or positive margins. Or if the tumor size is centimeter or greater than 2 centimeter, within one of the following, which will be additional risk factors like LBI or ER negative or grade 3 tumor. Or
LBI, ER negative. Yeah, well, after this trial, tumor is T0 and LVI positive, will you do radiotherapy?
T0 and LVI positive.
T0 and 0 LVI positive.
मुझे फिर एलबीआई देखो ना बायोप्सी
The best approach.
So then we'll drink with the respect.
If suppose it is
So we will consider the T
T1
before the
T1 and it can give. You will give. Okay, this style they won't mention anything of the ENI. External extension. क्योंकि आजकल काफी बात हो रही है ENI. So you will get larger tumor size, number one. The tumor margins are positive, number two. और क्या है? Lymph node. Multiple lymph nodes are present.
सॉफ्टवेयर
इन्होंने तो क्लोज मार्जिन भी 0.1 को भी इंक्लूड किया स्टडी में। अब अभी तक हम जो चीजें कर रहे हैं सब उसके उल्टा है।
जैसे बोलते हैं नो इनफॉर मार्जिन, लेकिन नो मतलब बस वही है उसका तो क्राइटेरिया पॉजिटिव नेगेटिव का। 0.1 को आप क्या बोलोगे? नो इनफॉर मार्जिन ही हो, वो नेगेटिव हो जाएगा।
NCV 51 का एरो किया।
उस ट्रायल में they found out that there was no overall survival, there was no tangible benefit doing the breast axillary sorry regional node irradiation. उसमें उन ट्यूमर जो पहले नोड पॉजिटिव ट्यूमर थे न्यू एडजवेंट कीमोथेरेपी देने के बाद जिनका नोड नेगेटिव आ गया था उसमें कोई बेनिफिट नहीं मिला था रीजनल नोड इरिटेशन करने में। रीजनल मींस फॉर nodes which were positive like axillary symptoms,
Axillary.
internal memory, infraclavicular and superficial.
So plus there is now considered as a regional. So latest study classification is
We consider as NCC.
Extend metastasis. So that is not considered as patient comes as the surgeon first see the patient. Then it should be very clear that what are the indications where you will advent your right side on the side. Right left. In the left breast. Any difference when you are using radiotherapy?
We can see if the tumor is on that side, we can use additional techniques.
Can they?
Oh, sorry. We can
Standard.
we will use additional techniques to prevent the cardiotoxicity.
What?
With the help of DIPH. So we have technique called DIPH with the help of
A little bit of all of us just want to know what is it.
मशीन के सारे पेशेंट को ब्रेथ होल्ड करवा के रखते हैं जैसे लंग का वॉल्यूम जब पेशेंट एक्सपायर करता है
40 मैंने कहा सबके बेनिफिट के लिए तो लगा आधी कुछ डिसाइड किया
पेशेंट को एक्सपायर करने के लिए तो पेशेंट का लंग वॉल्यूम एक्सपैंड करता है इससे हमें स्पेस मिलता है कि हम हार्ट को रेडिएशन से बचा सकें।
So it's the only breath hold or there is something special has come in this software in the machine where you can avoid those things.
बेनिफिट ये होता है जब वो ब्रेथ होल्ड कर पाता है पेशेंट तभी रेडिएशन सॉफ्टवेयर प्रोवाइड करता है जब भी पेशेंट इन केस ब्रेथ ना होल्ड करता है तो वो रेडिएशन नहीं होता तो उससे भी रिजेक्ट करते हैं।
Any other question?
मुझे एक तो ये देखना पड़ेगा कि ब्रेस्ट कैंसर की फाइल अगर आप एंसिलरी एंडपॉइंट्स ना लो तो इतना फॉलोअप लगता है to come to an मतलब less than 2% demonstrate करने के लिए उनको 10 years wait करना पड़ा. Same happened with alcohol और मतलब it takes a lot of time. So
We are we have seen many patients who are coming after 12 years or 15 years with some bone weakness. I have two patients I operated about 15 years back. And few of them they come with these spine metastasis. After 15 years they are coming with metastasis. But it's long follow-up required in the breast as well as in the thyroid also.
commendable अब जो उतना वो ट्रीटमेंट एडवांस हो गया तो इसका कोई सेंस नहीं बनता. मुझे ऐसा लगता है कि अगर हम अपनी सेटिंग में अगर हम लिटरेचर रिव्यू कर रहे कि इंटरमीडिएट इसमें एब्रिविएटेड आरटी हो तो हम आरटी कंप्लीटली स्किप करने की बजाय नाउ द क्वेश्चन शुड बी इट कैन बी शॉर्ट ड्यूरेशन लेस डोज क्योंकि कार्डिक टॉक्सिसिटी की दिख तो रही नहीं है. पंकज सर ने हमको पूरी लिस्ट दी थी जिन जिन लोगों को हमने लेफ्ट साइडेड आरटी करवाया था. तो वी वर कॉलिंग देम कि तुम आके अपना फ्री इको करवा लो. 2 लोग आए थे मात्र. तो मतलब वो तो पुराने में थे तो कोई इससे फर्क भी नहीं पड़ रहा है तो इसकी कार्डिक टॉक्सिसिटी दिख ही नहीं रही.
इतनी मेजर टॉक्सिसिटी आती ही नहीं है.
हाँ
रेडिएशन से 15 सेक्शन भी इजीली ले लेता है पेशेंट.
हाँ
तो उसमें ऑलरेडी आगे पे फोकस करते हैं मिनिमम से
मतलब पहले से जैसे पेशेंट को पहले से कोई कार्डियक डिजीज हो या फिर कीमोथेरेपी जो एंथ्रासाइक्लिन और ये हरसेप्टिन का भी इफेक्ट रहता है तब वो ज़्यादा क्यूमुलेटिव होता है अदरवाइज इतना नहीं
और
क्योंकि वो
पेशेंट भी इजीली कंप्लीट कर लेता है. जैसे हेड एंड नेक में पेशेंट के लिए बहुत कम्बरसम होता है कंप्लीट करना बट
35 रहते हैं इसमें उससे 15 ही रहते हैं ये ऑलरेडी कम रहता है बस.
और साइड इफेक्ट भी नहीं आते.
तो ये मैं कह रही थी ऐसा कोई लंग टॉक्सिसिटी कार्डिक टॉक्सिसिटी दिख नहीं रही. ओनली थिंग इज टाइम टॉक्सिसिटी.
अगर सर्वाइवल में डिफरेंस नहीं है पर रिकरेंस में कुछ तो मतलब
बस
डिफरेंस है
इसमें
तो मतलब
चेस्ट वॉल रिकरेंस ही एक आया है कि उस वो कम हो रहा है.
और मैम ये जैसे नंबर ऑफ पेशेंट इतने कम है 800 इतने में हम एक जस्टिफाई रिजल्ट दे देंगे कि अब हम के omit कर सकते हैं. ऐसे तो नहीं आ सकते ना मतलब बिल्कुल एंड पॉइंट में एक पेपर के
क्योंकि वैसे भी उनकी स्टैटिस्टिकल उन्होंने टारगेट करके थे वो डेट पर इतना सैंपल साइज वो कर भी नहीं पाए.
इंटरनेट बहुत पेशेंट बहुत अच्छा 1000 से कम नंबर का नंबर बस एक ग्रुप में इंटरनेट पेशेंट बहुत सो ये नहीं रहता.
सिस्टमिक थेरेपी में एक बात कर दिया तो आप आरटी को और माइनस कर सकते हैं. मतलब जब वो जैसे जाने पर वो हुआ तब सिस्टमिक थेरेपी सीएमएस थी. जब इन्होंने किया तो सिस्टमिक थेरेपी एसी और टैक्सेन आ गया. अब तो और भी चीजें आ गई है कि रोल ऑफ पार्टी में एक्चुअली हो जाओ.
लास्ट में जो सैंपल साइज था
एक्सक्लूजन क्राइटेरिया
बाद
एक्सक्लूजन क्राइटेरिया नहीं डाला था इंक्लूजन ये ये तो eligibility
इसमें the patient who had received and divided in city were eligible in the department. अब वो बाद में चेंज किया वो मतलब बाद में
आई क्लाइंट देखी कि वो कीमत दे वाला प्रोटोकॉल अमेंडमेंट एंड
amendment protocol amendment
widened eligibility criteria patients who had received systemic chemo. तो फिर से मैं ये बोलूंगी कि आप ये देख लो कि इंटरमीडिएट में एब्रिविएटेड आरटी में कहते हैं उसका वेरिएंट मोर सिग्निफिकेंस है इंस्टेड ऑफ कंप्लीटली ओमिटिंग इन आवर साइड.
well of course as you was telling based on this plan only we cannot change our practice. We have to discuss this more and see the more papers and meta analysis before any practice, but of course it's a insight in the plan. Any other comment? Probably it's looking like that these valuables from the medical officer, they are trying to take over all the treatment of the cancer. Previously, they omitted surgeons that surgery is not required, give NACT and then
इसलिए मैं आपको आपने एक डिस्कशन रखा था de-escalating RT, एक रखा था de-escalating surgery.
apply some software where you can say de-escalate. Otherwise, these people of the medical officer.
सर एक नया वर्ड आ गया है, ग्रीन कीमोथेरेपी.
Green.
हाँ, ये चाइना में जो है बहुत ज़्यादा यूज हो रहा है. तो वो बायोएक्टिव कंपाउंड्स को निकाल के उसका कोई कॉम्बिनेशन बनाते हैं और कीमो के रिप्लेसमेंट में ये देते हैं. एक पेशेंट था भोपाल से, तो टाटा मेमोरियल ने उसको रिकमेंड किया था वहाँ. वो कीमो करा के आया सर, उसको बहुत आराम मिल गया.
कुछ कंपाउंड निकालते हैं, कीमो वाला कंपाउंड तो नहीं निकाल.
ये बायोएक्टिव मतलब उसके साइड इफेक्ट्स नहीं है सर.
तो प्लांट की निकालने का बिल्कुल वो क्या निकाल रहे हैं, तो उसको भी तो उनको फॉर्मूला अल्टीमेटली बताना है. हाउ इट इज डिफरेंट फ्रॉम द ड्रग्स व्हिच आर एक्सपेक्टेड. मोस्ट ऑफ द
क्या भी 2-3 दिन पहले नशे नहीं पड़ा, ज़्यादा नॉलेज मुझे भी नहीं है.
So now it could be started. Now I will request those new doctors to join that they introduce themselves.
Good morning, sirs and ma'am. I'm Dr. Mrinalini Singh, a maxillofacial surgeon. Currently, I joined this hospital as a fellow in head and neck. Sir, I completed my MDS from MP City College, Gwalior, and BDS from Sri Aurobindo College, Indore.
Morning everyone, I am Dr. Megha Rai. I have joined as a fellow in head and neck oncology. I have completed my MDS from the Shraddha University, Greater Noida, and BDS from the Aurobindo Dental College, Indore.
My name is Dr. Tidiksha. I completed my MDS from BB Shetty, Bangalore, and BDS from Manipal College, Manipal. I have joined as a fellow in head and neck.
आपको दो कैंडिडेट नहीं, अभी रिएनिमेशन है जरूर किया.
Second round to my interview. Because एक तो जो आईफोन पे बोला गया है हमको कि जब अपन किसी भी पेशेंट को सपोर्टिव केयर के लिए एडमिट करते हैं और फिर उसके बाद अपन रेसिडेंस अप्लाई करते हैं, तो कायदे से कोई पैकेज अप्लाई हो गया तो अपन को उसका पूरा हॉस्पिटल पे स्पॉन्सर करना पड़ेगा. तो जैसे मैं भी ये करती थी कि आईसीयू में एडमिट कर लो, 2 दिन की सपोर्टिव केयर है और फिर रेसिडेंस का पैकेज लगा देंगे. लेकिन वो रेसिडेंस का पैकेज इतना कम है कि उसमें वो सपोर्टिव केयर बनती नहीं है. तो बेटर होगा कि हम उसको घर भेज दें और फिर हम उसको 5-6 डेज के बाद बुला के दोबारा अप्लाई करें. तो हम वी आर नॉट ऑब्लिगेटेड टू स्पॉन्सर दिस पैकेज.
रिएक्शन थेरेपी में आपको जैसे 5 या 7 दिन बाद आता है तो क्लोज कर देते हैं और पेशेंट के बाद वापस आएगा. नहीं मिलेगा तो नहीं मिलेगा. तो कल मेरी भोपाल बात हुई थी, इनका कहना है कि अपन पिछला जो कारण है और तो वो पर रेडी का बच्चों पैसा दे रहा है. अगर 3 का पैसा दे रहे हैं, 10 सर्विस कर दिए तो उनके हिसाब से वो कैलकुलेशन प्लान है और ये मॉल वॉल का हम
रीअप्लाई करने में ज्यादा फायदा हो.
असल में केसेस पे डिपेंड करता है.
मतलब ज्यादा गैप हो गया तो मोल्ड भी रीडिजाइन करना पड़ेगा.
तो वो उसको दे ही नहीं रहे, प्लानिंग और मोड का नहीं दे रहे, उसको पर सेक्शन पे.
और एक बार तो दीजिए.
सेकंड ये भी है कि कुछ पेशेंट्स ऐसे हैं जो कि अपने रिसोर्सेज से दे आर गेटिंग सैंक्शन मनी फ्रॉम द एआर बाय प्राइम मिनिस्टर फंड और चीफ मिनिस्टर फंड से पैसा वो सैंक्शन करवा. आयुष्मान की भी कार्ड कुछ लोगों के पास होते हैं.
देख के परमिशन
लाइक वैसे 66 हैं पर वो 14 तो मतलब एक एक तीन चार फोटोग्राफ्स हैं और लाइक एडिंग की 14-15 स्लाइड हैं तो लाइक उतनी होंगी फोटो नहीं उसके साथ बस आई नो
यहाँ पर वहाँ सुनाई दे चिल्ला चिल्ला के नहीं रेडियोलॉजी इन लोग की नहीं होती आती है सर की भी बोला था आप क्या काटते हैं एमएलए सर की ट्रेनिंग लेने की क्या है टोटल मुझे बहुत लंबी उम्र है इधर आ जाओ एक एक मिनट बीच में बता दो थोड़ा सा चालू करके अच्छा अरे आगे आ जाओ बिल्कुल बिल्कुल आने वाले हाँ आ जाओ नहीं नहीं बंद आ जाओ लगती है और सब दफादार करने की तो कम निकल जाती है अभी ये आप काम जैसे सुबह हाँ सर चलो बात है नहीं अभी कर सकते हैं आई और जब हम आते हैं हम आपके जरूर नहीं घंटे के बाद अपने से गलत काम करें गलत जैसे हमारा
That this topic is very, very important for all of us. At least all we are working in a cancer institution. Be very well clear about the basics of the particular topic is really very, very important to understand that what exactly happens in the clinical cell process. Very important topic of this talk. Will be more wider.
Hello. Good morning, everyone. Today, my topic of journal club is hallmarks of cancer.
So these two researchers you're seeing on the screen, on the left side is Robert A. Winberg, and on the right side is Douglas Hannan. They have done tremendous research works in the cancer field, and one of their landmark paper, which was published in 2000, was the hallmarks of cancer. So in 2000, they gave us 6 core hallmarks, because at that time there was no unified model of cancer, and cancer was just merely an uncontrolled cell proliferation. There was a somatic mutation theory, but it was not fully explained. Pathways were known which causes cancer, but were not unified. And the cancers was specifically seen as merely a simple cell which invades and metastasizes. But according to them, the cancer cell biology was more complex, including the different types of cells which helps cancer to invade, proliferate, and metastasize. So if we talk about the carcinogenesis, when a normal cell first get a carcinogen-induced mutation, which we call as initiating mutation, it further acquires the stem cell-like properties, which further gets additional driver mutations and acquire these cancer hallmarks to form the founding cancer cell. And that cancer cell again gets additional mutations, uh, further gets the genetic evolved and leads to and becomes a genetically heterogeneous cancer.
Before that, I just tell you one more thing about this breast cancer. There was a hypothesis put forward by Bernard Fisher, very famous thing, that cancer breast to start with is systemic. So whatever local treatment we are doing for this, we are really going to cure the fever. So there was a common thing put forward that local control does not mean cure, but cure does not achieve without local. So this is these slides which we are going to present. They are very important so that it will highlight the pathophysiology of the cancer and what happens in a single cell and mutation occurs and carcinoma.
And so whenever first a normal cell gets a carcinogen-induced mutation, which we call as initiating mutation, that normal cell acquires a stem cell-like properties, which further gets an additional driver mutations, and those mutations acquire the cancer hallmarks, forming a founding cancer cell. And that founding cancer cell further grows on additional mutations, further gets genetically evolved into a genetically heterogeneous cancer. In 2000, they gave a emergent circuit of the cell, believing that a cancer cell has a big network regulating circuits that governs the normal cell proliferation and homeostasis. So according to them, cancer is a disease caused by dynamic genetic changes that transform normal cells into malignant ones through multiple steps. And these are driven by the oncogenes, tumor suppressor genes. Due to the cancer's complexity, research shows that a few core principles and cellular traits underlie most cancers. And these discoveries point to common mechanisms regulating cell growth, death, and interaction with the environment, which cancer disrupts to develop and progress. So, due to this complexity, there were a number of questions which were raised. So, how many distinct regulatory circuits within each type of target cell must be disrupted in order for such a cell to become cancerous? Does the same set of cellular regulatory circuits suffer disruption in the cells of the disparate neoplasm arising in the human body? Or which of these circuits operate on a cell autonomous basis and which are coupled to the signals that cells receive from their surrounding microenvironment within a tissue? So in 2000, they gave this emergent circuit, and they basically in next paper in 2011 they named those circuits. They gave different names such as motility circuits, differentiating circuits, viability circuits, proliferation circuits, and eventually all these circuits lead to changes in the gene expression and causing cancer. Another thing which they highlighted in these papers was that tumor microenvironment. A tumor microenvironment is increasingly recognized as a complex
dynamic organ-like system composed of cancer cells and variety of the supporting cells. We know tumor is basically made of stromal cells and parenchymal cells. Parenchymal cells are the cells which are cancer cells, cancer stem cells, and then the stromal cells are the cells which basically supports these cancer cells to grow, invade, and metastasize. And these stromal cells are endothelial cells, pericytes, uh, immune inflammatory cells. And there is a big connection between these both cells and regulating network which helps them to metastasize and invade further. Before going to the hallmarks, I just want to explain a little bit about the proliferation. As we can see on the screen, we have cell cycle. So we know that cell cycle has metaphase, has mitotic phase and then interphase. In interphase, we have G1, S, and G2. And if the most important two phases of the cell cycle are basically the mitotic phase and the synthesis phase, the S phase. And any mutation or defect which is carried towards these phases can lead to the cancer. There's different cell cycle components which helps a cell cycle to proliferate or which helps the cell cycle to decide whether the cell should proliferate or not. If I talk about these two checkpoints written on the screen, the G1S checkpoint and G2M checkpoint, these are the really important restriction points which decides whether the cell should progress further or not. And G1S checkpoint is really, really important because once the mutation goes forward from this G1S checkpoint, that cell will undergo, that will be a complete cell cycle. So if mutation pass from the G1S checkpoint, that will be carried on further towards the mitosis and the cancer can happen. So we have cell cycle components such as cyclin and cyclin dependent kinase, which basically allows the cell to progress through this G1 checkpoint. Then we have those cell cycle inhibitors which inhibit these cyclins such as CYP family and INC4 family. And then we have two really important checkpoint components which is RB and P53 which are tumor suppressor genes. So conceptually there are three types of cancer genes. So we have oncogenes, we have tumor suppressor genes, and then we have DNA repair genes. And in normal cell, the balance between this proto-oncogene and tumor suppressor gene is there. So if a proto-oncogene gets mutated to the oncogene, that means there will be too much proliferation. So oncogene is basically a gas, it means too much proliferation, and the tumor suppressor gene is basically brakes, means which controls the proliferation. So too much oncogene, too much gas means leading to the cancer, and whereas if there's no brake, tumor suppressor gene is inactivated, it will eventually lead to cancer. And this is the table taken from the Robbins Book of Pathology, where they have mentioned different oncogenes. So basically we have proto-oncogenes, which further gets overexpressed or amplified or get mutated into oncogenes and cause different associated human tumors. For example, we have proteins involved in the signal transduction. As we can see, GTP binding proteins such as KRAS, HRAS, NRAS. Whenever there's a point mutation in any of them, they eventually lead to the cancer. We have nucleoregulatory pathways such as transcriptional activators such as MYC and NMYC, which again have translocation amplification can lead to further types of cancers. If I talk about tumor suppressor genes, as we can see on the screen, we have different genes having different functions, and if they get mutated, can lead to familial syndromes and sporadic cancers. Two really great examples, RB and P53. RB is written in there in the left side. It's an inhibitor of cell cycle progression. So the function of RB is basically it's inhibit the G1S transition during the cell cycle progression, and if it's mutated, it can lead to familial syndromes or sporadic cancers. On the right side, there's TP53 under the enablers of genomic stability, and TP53 function is basically to sense any kind of mutation or defect so that it can allow the apoptosis in response to the DNA damage. And mutation in T53 can further cause syndromes and cancers. Another is the DNA repair genes such as BRCA1, BRCA2, which helps us in repair of double-stranded breaks in DNA. And any mutation in these genes, as we know, can lead to familial breast and ovarian cancers. Coming back to this specific part of the cell cycle, we have different growth factors which allow cells to proliferate, and then we have growth inhibitors, which stops the cell to not proliferate. So basically, the RB is actually bound to elongation 2 factor, and whenever we need the proliferation, this elongation 2 factor is released and is bound to the site, transcription site, and the transcription is activated, and the cell further goes from G1 phase to the S phase. So let's say for growth factors, whenever growth factors bind to the growth factor receptors, the cyclin DNA gets activated, they hyperphosphorylate the retinoblastoma, and the elongation 2 factor is released, is bound to the site, and the transcription happens. On the other side, if I talk about growth inhibitors, they actually stimulate these CDK inhibitors, the CYP family and INK4 family. They inactivate those cyclins, so the RB remain hypophosphorylated, so the transcription is. Another really important uh, in the cell cycle progression is the downstream signaling pathways. So these are the pathways which are activated after the growth receptor stimulation, which drives the cell cycle progression. And two really important pathways which are also really mentioned again and again in the hallmarks is these two pathways. One is the MAPK pathway shown on the left side, and then we have PI3K mTOR pathway which is on the right side. So the MAPK pathway is basically whenever any epidermal growth factor binds to the receptor, they activate the RAS, and that RAS, activated RAS, further activates the RAF, MEK, and ERG, and leads to the proliferation. On the other hand, the PI3K pathway, whenever PI3K get activated, it converts the phosphoryl 2 to 3, and then further PIP3 activates AKT, which also has a function of survival, increase the survival in the cells, and again it activates mTOR, which further helps in the proliferation and angiogenesis. So coming back to the hallmarks, in 2000, on the left side of the screen, you can see the 6 core hallmarks which were given in 2000 by the Winberg and Hanan. So these were self-sufficiency in growth signals, evading apoptosis, insensitivity to anti-growth signals, sustained angiogenesis, tissue invasion and metastasis, limitless replicative potential. In 2011, they named these 6 core hallmarks, and they also gave additional 2 emerging hallmarks, which were deregulating cellular energetics, avoiding immune destruction, and they gave 2 enabling characteristics, that was genome instability and mutation, and tumor promoting inflammation. So hallmarks is something which helps the cancer cell to acquire the mutation and to become the helps it to become malignant. And the enabling characteristic is something which facilitate those hallmarks, or which facilitate the cancer cell to acquire those hallmarks fastly. And later in 2022, they included these 4 hallmarks with those 6 core hallmarks and given 10 core hallmarks. So now we have 10 core hallmarks and 2 emerging hallmarks which are written in blue, which is unlocking phenotypic plasticity and senescent cells, and 2 enabling characteristics, non-mutational epigenetic reprogramming and polymorphic microbiomes. So starting from the first hallmark is sustaining proliferative signaling. So when we talk about normal cell, the normal cell depends on signals from outside the cells, such as growth factors, cytokines, extracellular matrix, and cell-to-cell adhesion molecules. And when these signals are received by specific transmembrane receptors in the cell surface, it leads to cell growth and proliferation. But cancer cells escape this control and start growing without even needing those external signals with following mechanism. So we have autocrine and paracrine stimulation. So when cancer cells overproduce growth factors by themselves effectively, stimulating their own receptors continuously without even any external input, which is known as autocrine signaling. And they also coerce the surrounding stromal cells to release the growth factors that fuel the cancer growth. So cancer cells may increase the number of growth factor receptors in their surface or acquire the mutations that make this receptor active without the presence of the ligands. And mutations can also activate signaling molecule downstream of the receptors, bypassing the need for receptor altogether. Another mechanism is somatic mutations and constitutive signaling. Various genomic studies of tumor have identified the mutations that causes continuous activation of signaling pathways typically triggered by growth factor receptor, such as BRAF. So as BRAF mutation in melanoma, we know about 40% of the melanomas have mutation in BRAF, which is a component of the MAPK pathway, causing constant proliferative signals. And these mutations allow the cancer cells to grow independently of the normal external signals, and different pathways can be affected, influencing the tumor behavior and response to therapies. Another mechanism is disruption of the negative feedback mechanism. So cells have built-in negative feedback loops that keep proliferative signals check and maintain homeostasis. One of these mechanisms are written there's RAS mutations. So again, the two downstream pathways which I have explained earlier, this is the same pathways. So we have the MAPK pathway and we have the PI3K pathway. So whenever we need proliferation, the growth factor bound to growth factor receptors, the inactive RAS gets active and further activate the transcription. But if we have mutation in the RAS, so the active RAS normally, whenever we do not need proliferation, that active RAS gets inactivated by hydrolysis. And when there's a mutation, that active RAS cannot get inactive and it stays active. And that active RAS always leads to the cellular proliferation. Another example is loss of PTEN. So PI3K, as I earlier mentioned, that PI3K converts phosphoinositide 2 to 3, which further activates AKT. Now, the function of PTEN is to convert back that phosphoinositide 3 to phosphoinositide 2. So if we have loss of PTEN, there will be continuous activation of AKT leading to the cell death. Another hallmark of cancer is evading growth suppressors. So cancer cells not only promote their own growth signals, but also actively evade mechanisms that normally suppress proliferation. And this ability of evading the growth suppressors is critical for uncontrolled tumor growth and involves disrupting the tumor suppressor genes. So role of tumor suppressor genes is basically acting as a brakes on the cellular proliferation. Whenever there's an unfavorable conditions such as DNA damage or inadequate nutrient or stress signals, they halt the cell cycle. And two most important well-defined tumor suppressors are RB, retinoblastoma protein, and TP53. So RB acts as a gatekeeper for the cell cycle. It integrates multiple internal and external signals to decide whether a cell should proceed to divide or pause. And normally, RB restricts the cell cycle progression from the G1 to the S phase. And so loss of RB function removes the critical checkpoint leading to the uncontrolled proliferation. Our TP53, often called as the guardian of genome, it basically functions as monitoring the internal cellular stress, such as DNA damage, nutrient deprivation, or hypoxia. So it can pause the cell cycle to allow repair or induce cellular senescence or apoptosis if damage is irreparable. But there's a thing called network redundancy and its implications. Although the retinoblastoma and TP53 are key regulators, the cellular proliferation control network is functionally redundant. Evidence shows that the loss of RB or TP53 alone in the mice often does not immediately cause rampant proliferation of the cancer. For example, mice with cells lacking the RB throughout many tissues often still shows the normal tissue morphology and only develops tumor late in specific organs. Similarly, in TP53, null mice also develop normal with proper tissue homeostasis before cancer arises later. So this suggests that there are other mechanisms that compensate for the loss of these suppressors, limiting immediate tumor genesis but potentially falling over time or in combination with the additional mutations. Another mechanism is by contact inhibition and evasion. So normal cell, whenever so a distinct form of growth suppression occurs when cells densely contact each other. That means whenever a normal cell grows and it feels it has achieved the size, it will stop proliferating. This contact inhibition stops normal cell from proliferating excessively, forming organized tissue structures. And cancer cells frequently lose this property, allowing continued division even in the crowded environments. Two tumor suppressors which are involved in the contact inhibition are Merlin and LKB1. Merlin, we know, is a links with the cell adhesion molecules and E-cadherin. So basically, it links E-cadherin to the receptor tyrosine kinase, such as the EGF receptor, and basically strengthens the cell-to-cell adhesion and sequester growth factor receptors. If there's a disruption of Merlin, as we see in neurofibromatosis type 2, this disrupts contact inhibition and actually supports the tumor development. Another one is LKB1, which we found that LKB1 mutations are found in some human cancer, highlighting its role as a growth suppressor. The main function of the LKB1 is it maintains the epithelial tissue architecture and this suppresses the transformation by oncogenes such as MSC. Another pathway is TGF beta pathway from suppressor to promoter of malignancy. So transforming growth factor beta is a cytokine that normally inhibits the cellular proliferation and function as a tumor suppressor in early stages of the cancer. So cancer cells finds a way to evolve and ways to evade the TGF beta suppressive effects, including losing the responsiveness to the TGF beta anti-proliferative signaling, rewiring the TGF beta signaling to promote the epithelial to mesenchymal transition, and the switch from a tumor suppressive to pro-metastatic role exemplifies how cancer cells manipulate growth suppressor pathways to their advantage. Next hallmark is resisting cell death. So normally, programmed cell death process like apoptosis, which acts as a natural barrier. Whenever there's a damage, we have mechanisms in our body which helps us to destroy the cell, such as apoptosis and necrosis. So apoptosis is basically programmed cell death. So in the right side of the screen, we can see an image in where intrinsic pathway of apoptosis has been shown. And apoptosis actually works with the help of P53. So apoptosis also have different genes, different proteins. So we have pro-apoptotic proteins, we have anti-apoptotic, and then we have the sensor genes. So pro-apoptotic will be helpful in proliferation, anti-apoptotic will be helpful in stopping the regulating those proliferation. So whenever a normal cell has to proliferate, so whenever there's a DNA damage, the P53 will check for that damage and will activate those sensors such as BAX and BAC, and then it will lead further to the apoptosis. But if there's a mutation of any P53, or there's a loss of P53 function, that will disable the key sensors and it will prevent the apoptosis. So cancer cells develop various mechanisms to suppress the apoptosis. So first is the loss of TP53 function. Second is upregulation of the anti-apoptotic proteins such as BCL, MCL. And another one is downregulation of the pro-apoptotic proteins. So lower level of BAX, PIM, or sensor proteins like PUMA reduce the cell ability to undergo apoptosis. Another one is impairment of the extrinsic death signaling. So the cancer cell can block the death receptor activation pathways. Another mechanism is autophagy. So autophagy is another form of programmed cell response where cells degrade and recycle their own components during stress, especially nutrient deprivation. So autophagy involves the formation of autophagosomes that engulf cellular organelles and fuse with lysosome for degradation. This regulation overlaps with the apoptotic pathways, and usually a protein known as Plaquenil-1 protein is essential for autophagy and is connected to the apoptotic BCL2 family proteins via BH3 domain. So if there's a genetic loss of the Plaquenil-1 or autophagy, this gene increases cancer susceptibility, indicating that autophagy can act as a barrier to tumorigenesis. However, autophagy can also promote tumor cell survival by helping the cancer cells endure the metabolic stress and survive treatment. So some cancer cells use autophagy to enter a dormant drug-resistant state, contributing to the tumor relapse. Another factor is necrosis. As unlike apoptosis, so necrosis and apoptosis are basically leading to the cell death. The main difference is that whenever necrosis happens, it also has an inflammation. So whenever necrosis happens, the cell swells, cell ruptures, and release that cellular contents in the tissue environment. That means if the necrotic cell triggers a death, the inflammation will be released by releasing the pro-inflammatory molecules and recruiting the immune cells. Although inflammation normally helps clear dead cells in the tumors, but inflammatory cells can paradoxically promote cancer by enhancing the blood vessel formation, stimulating the cancer cell proliferation and invasion, and also necrotic cells release factors like interleukin 1 alpha, which can directly encourage proliferation of nearby tumor cells. Thus, while necrosis eliminates the damaged cells, it can inadvertently support tumor growth and progression by creating a pro-tumor microenvironment. Next hallmark is enabling replicative immortality. By name suggests itself, is the ability to replicate indefinitely. So it's a really crucial property cancer cells must acquire to form large clinically evident tumors. And there are some barriers for the unlimited replication. One is senescence and crisis, the mitosis crisis. So normal cells typically face two main proliferation barriers. One is senescence, a state in which cell permanently stops dividing but remains metabolic active. This is usually irreversible. Another is mitotic crisis, a phase characterized by widespread cell death, primarily due to genetic instability caused by chromosome abnormalities. So when normal cells are cultured, they usually divide only a limited number of times before entering senescence, and some cells may bypass senescence but ultimately enter crisis, where most of them die. Rarely, a cell escapes the crisis and gains the ability to proliferate indefinitely, and this process is known as immortalization. There's a big role of telomeres and telomerase. So what telomeres is, they are the repeated DNA sequences at the end of chromosomes to protect the chromosome integrity. And every time this normal cell replicates or normal cell divides, the telomeres get shortened. So telomeres shorten progressively with each cell division, eventually causing loss of chromosome and protection, formation of unstable dicentric chromosome leading to chromosome rearrangements and dysfunction, and then entry into crisis or senescence once the telomeres become critically short. On the other hand, we have telomerase, which basically adds back the telomeres onto the chromosome ends. And normally, in normal cells, the activity of telomerase is really less or very low, but in the cancer cells, it is expressed really high. So what telomerase does is, by extending the telomeres, they prevent the critical telomere shortening. They enable cells to bypass the senescence and crisis, and they confers unlimited replicative potential immortality. This can be explained by this picture. So as we can see, when the telomerase is inactive, means telomeres are keep on getting shortened with the multiple cell divisions. Now, once the cycle, when the cell has achieved those cell divisions, the p53 will will be activated, and the cell will undergoes the senescence. If there's a mutation in p53, the cell will pass that G1S checkpoint and further goes to the mitosis. Now in mitosis, there's a way of again checking the mutations by the help of the non-homologous end joining pathway. So when this mutation goes further into the mitosis, there's a bridge fusion breakage cycle where it keeps on getting new double-stranded breaks all over again and again. Now again, if there is telomerase absent, which is happening normally, that will lead to the mitotic catastrophe. But if telomerase is reactivated, as we see in the cancer cells, it will further lead to the cancer. Next hallmark is inducing angiogenesis. So tumors like normal tissue needs a steady supply of oxygen and nutrients and an efficient system to remove waste products. And this critical support comes from the formation of new blood vessels, a process called angiogenesis. And this is regulated by something known as angiogenic switch. So angiogenic switch is controlled by a balance of factors that promote or inhibit the blood vessel formation. We have proangiogenic factors, for example, vascular endothelial growth factor A key protein that stimulates the endothelial cells to grow new vessels. And we have anti-angiogenic factors, for example, thrombospondin 1, which binds receptors on endothelial cell to suppress the angiogenesis. So multiple molecular layers modulate these signals. So VGF ligands can be stored in the extracellular matrix and released by protease, enabling precise local activation of the angiogenesis. And other growth factors such as fibroblast growth factors family also contribute to tumor blood vessel formation. Tumor cells can directly induce the angiogenesis through oncogene activation such as RAS and MYC, upregulating those pro-angiogenic factors, and immune cells infiltrating tumor cells can also produce these signals, underlying how distinct cancer hallmark traits such as sustained proliferation and angiogenesis can be co-regulated. The body produces endogenous inhibitors that modulate the angiogenesis to maintain tissue balance and restrict that inappropriate vessel growth. Beside the thrombospondin 1, other inhibitors are angiostatin and endostatin. And these inhibitors circulate normally and prevent the unchecked angiogenesis, but are often overridden in the cancer. And mouse models have shown that loss of such inhibitors enhance tumor growth while increasing their level impairs tumor progression. Next hallmark is activating invasion and metastasis. So this process by which cancer cell invades surrounding tissue and spread to the distant sites. So it happens through activating invasion and metastasis. So progress over recent decades has shed light on the complex cellular changes, molecular pathways, and interaction that enable these capabilities. So first mechanism is cell adhesion and invasion. So when there's a loss of E-cadherin, so basically E-cadherin is a cell-to-cell adhesion molecule that maintains the structure. And loss or downregulation of this E-cadherin disrupt tissue architecture, enabling increased motility, detachment of cancer cells from their neighbors, enhanced invasive ability, and this is supported by frequent downregulation or mutation of E-cadherin in many human carcinomas. We have invasion metastasis cascade. So we have different steps. So first we have local invasion. So cancer cell infiltrates in the surrounding tissue. We have intravasation, entry into nearby blood or lymphatic vessels. Then we have transit, circulation through lymphatic and blood vessels. Extravasation, now they exit from the vessel into a distant tissue parenchyma. Micrometastasis formation and colonization. And each step demands specific cellular adaptations. Two more mechanisms which helps cancer to metastasize is epithelial mesenchymal transition and also stromal cells. Now stromal cells I have explained earlier in that picture in the tumor microenvironment that stromal cells supports the cancer cells to further disseminate, invade, and metastasize. When we talk about metastasis, it occurs in two main phases. We have dissemination and colonization. The dissemination is basically physical spread of cancer cells from the primary tumor, and colonization is adaptation and growth in distant organs. But many micrometastases disseminate but fails to grow into overt tumor, potentially due to dormancy induced by lack of angiogenesis, nutrient deprivation, anti-growth signals, and immune system suppression. So if I explain this picture, we can clearly see the metastatic dissemination happening. So there's a connection between the parenchyma and the stromal cells. So whenever we have the cancer cells, the incipient cancer cells or the cancer stem cells, they recruit the stromal cells to the lesion. So now there's a relation going on between the parenchyma and stroma. And whenever the stromal cells undergo primary tumorigenesis, they form nascent stroma of the primary tumor, which further helps the incipient cancer cells to form the further cancer cells and cancer stem cells, which further helps the nascent stroma to form the supportive stroma of the primary tumor. And that supportive stroma of the primary tumor helps that cancer cells to form invasive cancer cells. And these invasive cancer cells now can further disseminate and cause micrometastasis. And when these micrometastasis happens, they recruit the stromal cell to the serine metastasis and forming the normal stroma and including the normal stroma. Now this normal stroma again becomes nascent stroma of metastasis, again leading to the macrometastasis and supporting stroma of the metastasis happening. So basically this actually explains the seed and soil theory. So the cancer cells and cancer stem cells are the seeds and the normal stroma or the stroma acquired by these cancer cells are the soil. So whenever the cancer goes to a specific space or place, they make an environment for themselves before even metastasizing or after going there. Another hallmark is genomic instability and mutation. So cancer progression depends heavily on genetic alterations, And one of the key enabling factors underlying these changes is genomic instability and mutation. And this instability accelerates the accumulation of mutations and epigenetic changes that grant the cancer cell selective growth advantages, where clonal evolution and mutation acquisition, so they acquire either genetic mutations or they undergo epigenetic alterations. So cancer cells often display elevated mutation rates due to increased exposure or sensitivity to the mutation factors, and the gene involves DNA damage detection or repair pathway activation, such as ATM or ADR, direct DNA repair mechanism, example BRCA1 or 2 in homologous recombination, and neutralizing those mutagenic parts. And loss of these caretaker functions leads to accumulation of mutation and genomic aberrations that fuel the tumorigenesis. Next hallmark is tumor promoting inflammation. So tumor promoting inflammation is a key enabling characteristic in cancer development and progression. While inflammation is typically a protective response to injury or infection, paradoxically it fosters the tumor growth and malignancy. So inflammation contributes to multiple hallmark capabilities of cancer by supplying the bioactive molecules to the tumor microenvironment. So inflammatory cells such as TAMs, cytokines, chemokines, and growth factors that stimulate the cancer cell proliferation, survival, angiogenesis, and invasions. So there's an early role in tumor initiation and progression. So inflammation also is evident in the earliest stage of neoplastic progression, and the key signaling pathways involved in that tumor promoting inflammation includes nuclear factor kappa beta, JAK-STAT, MAPK. Whenever these pathways are activated by the cytokines and other inflammatory mediators, regulating gene involved in cell survival proliferation, immune evasion, and EMD. Next hallmark is deprogramming energy metabolism. So as we know, the cancer cells reprogram their energy metabolism to support the uncontrolled proliferation, a hallmark of the neoplastic disease. So basically, normal cell in our body converts the glucose to pyruvate and basically uses the oxidative phosphorylation, efficiently generating the ATP. But in anaerobic condition, the cell rely on glycolysis, giving less ATP but maintains energy production. But the cancer cells, however, preferentially metabolize glucose via glycolysis even when the oxygen is abundant, hence naming aerobic glycolysis. So even this glycolysis, the aerobic glycolysis give less ATP. The cancer cell actually compensate by increasing the glucose uptake via the GLUT1 transporters. They upregulate the glycolytic enzymes. They have hypoxic tumor microenvironments which further induce the glycolysis through stabilization of the transcription factors. And this preference for glycolysis despite lower ATP supports rapid cancer cell growth by diverting the glycolytic intermediates into biosynthetic pathways vital for proliferation. So these include the nucleotide synthesis, amino acid synthesis, and lipid synthesis for the membrane. And such biosynthetic demands are critical for producing the macromolecules and organelles in dividing cells. Next is evading immune destruction. So evading the immune destruction is also a critical hallmark for cancer, allowing tumor cells to escape the detection and elimination by the immune system. So normally the immune system monitors tissue and destroys the abnormal cells, including early cancer cells, through a process called immune surveillance. So we have two processes, we have immune surveillance and immune editing. Immune surveillance is basically cytotoxic T cells and natural killer cells constantly patrolling the body for abnormal cells and eliminating them. Evidence from the animal studies showed that mice with a weakened immune system develops tumors more frequently and rapidly, highlighting the immune system role in suppressing cancer. Another process, immunoediting, where the immune system shapes tumor evolution by eliminating highly immunogenic cancer cells, leaving behind the weakly immunogenic variants. So basically, how cancer cell evades the immune destruction? They downregulate or lose major histocompatibility complex 1 molecules, making them less visible to the T cells. They secrete immunosuppressive factors like TGF-beta, which inhibit the activity of cytotoxic T cells and NK cells. Cancer cells recruit regulatory T cells and MDSC, which actively suppress the immune response, and also immune checkpoint activation, such as cancer cell upregulate the immune checkpoint molecules. So next is the emerging hallmark, which is unlocking phenotypic plasticity. So basically, phenotypic plasticity includes three main processes. We have dedifferentiation, block dedifferentiation, and trans dedifferentiation. So when we talk about the normal differentiation, the progenitor cells normally divides and normally forms a cell. In dedifferentiation, what happens is that cells normally undergo differentiation, forms a cell, but then further go back to the progenitor state. So divides normally and go back again to the progenitor state. In block dedifferentiation, what happens is the cell cycle progression halts in the midway and forms a lot of immature cells, as we seen in the leukemia. And in trans dedifferentiation, what happens is the cancer cell actually changes the lineage in between. So a cancer cell, for example, in the basal cell carcinoma, can switch to a different cell type to escape the hedgehog pathway inhibition, acquiring resistance to the target therapy. So phenotypic plasticity is really important in therapeutic resistance because phenotypic plasticity is also a major factor as it can switch lineage or states to evade the targeted treatment. Next is the enabling characteristics such as non-mutational epigenetic reprogramming. So we know that there is mutational epigenetic reprogramming, but non-mutational epigenetic reprogramming is also an essential enabler characteristics, which operates independently of the DNA mutations. So epigenetic reprogramming mechanisms such as DNA methylation, histone modification, and chromatin remodeling regulate gene expression and are central to normal development and differentiation. In cancer, these mechanisms are hijacked to drive hallmark capabilities, and the tumor microenvironment significantly influences the epigenetic reprogramming. So factors like hypoxia, nutrient deprivation, physical properties of extracellular can induce more epigenetic changes. So non-mutational epigenetic reprogramming is a bona fide enabling characteristic that facilitate the acquisition of the hallmark capabilities in the cancer. Next, enabling characteristics is polymorphic microbiomes. So as we know, every barrier in our body has different microbiomes. So these different barriers modulate the these different barriers have different microbiomes which modulate different tumor growth, inflammation, immune invasions, genome instability, and therapeutic resistance. So microbiome actually modulates both innate and adaptive immune response, and bacteria can reach the gut barrier, trigger immune responses, create tumor promoting or tumor antagonizing immune microenvironments. And also there's an intratumoral microbiota. So bacteria have been detected within the solid tumors and their presence is associated with clinical pathological features. The studies shown that the tumor microbiome can influence tumor promoting inflammation and malignant progression. The last hallmark is the senescent cells. As it was earlier discussed in one of the hallmarks, cellular senescence is considered as the main hallmark, the emerging hallmark. So cellular senescence is a state of irreversible cell cycle arrest that acts as a protective mechanism to maintain the tissue homeostasis by inactivating and removing damaged, dysfunctional, or unnecessary cells. This process is triggered by various stresses, including DNA damage, nutrient deprivation, and signal imbalance, and is a key feature of aging and cancer biology. So there's dual role of the senescence. While the senescence is protective, it can paradoxically promote cancer progression in certain contexts. So senescent cells actually secretes a bioactive molecule known as SASP, the senescence-associated secretory phenotype, which includes chemokines, cytokines, and protease, which further promotes the proliferative signaling, angiogenesis, invasion, metastasis, and immune suppression. Senescence is also associated with significant epigenetic and metabolic changes, and epigenetic modifications such as histone modifications and DNA methylation can drive the transition to the senescent state and influence the SASP. Also, there's a therapeutic implication of senescence. So targeting the senescent cells is a promising therapeutic strategy. So senolytic agents which selectively eliminate senescent cells and xenomorphic drugs which modulate the SAPs are being developed to overcome therapy resistance and improve the cancer outcomes. So basically, cellular senescence is a double-edged sword in cancer biology. While it initially acts as tumor suppressor by arresting the proliferation of the damaged cell, the persistent senescent cells can promote tumor progression through the cell and contribute to therapy resistance. Another thing which they included in the 2011 paper was the drugs. So they didn't mention most of the drugs or most of the hallmarks because they believe that most of these drugs are undergoing trial, and they didn't want to mention those drugs. But a certain group of drugs are actually using this hallmark ability to target the cancer. So we have different target therapies. We have EGFR inhibitors, for example. We have telomerase inhibitors and PARP inhibitors. That was the all. My reference was from these three papers, and all the images were from the Robbins Book of Pathology. Thank you.
Very good. These very well formulated. I like to in the beginning that this is very, very important for all of us oncologists to know because it is just the changing which occurs in the normal cell fiber. तो देख के लगता है 10 हॉलमार्क्स जो हैं अपने रावण के 10 से जैसे हाउ कैंसर डिफिकल्ट और जैसे हिरण्यकश्यप को वरदान था ना कि ना आसमान में मरुआ न मरुआ न रात में मरुआ न बाहर मरुआ न अंदर मरुआ न आदमी न जानवर कैंसर सेल भी ऐसे ही वरदान देके पहला उल्टी के मारो कैसे मरोगे एक रास्ता जाएगा दूसरा रास्ता पकड़ जाएगा तीसरा पकड़ I mean, there are so many mechanisms, and that's why there are so much drugs they have developed to kill at the different stages of cancer cell during the process of initiation, promotion, and progression. Well, topic is very vast and very little time to discuss, but very well covered. Yes, and thank you.
हम डेविटा में बेसिकली 2011 का जो पेपर है वही है सेम. हाँ हाँ, जो 2011 का इनका पेपर है डेविटा सेम वही है, एग्जैक्टली सेम. उसमें जो 2022 का वो नहीं है, 2011 का सारा है अप टू दिस ड्रग्स वाला. हाँ वो चैप्टर हो गया. I don't remember the name, but मेरे वाले एडिशन में ये 2011 का नहीं मतलब. I don't remember the edition name.
10. ज़्यादा होता है. I first secondary. Anyway, this is very good topic and very well covered again. And in fact, all of us should be aware of all these activities. Though there was an opportunity, I must mention here, Dr. Archana, about 15 years back, she was a fellowship in Japan. She worked on this signaling pathway. And it was a 6 month fellow, very well, my finest. So she was there, and I also got opportunity went to the Japan person. I see what water and everything. Work on this signaling, and she has also guided one candidate for this is on the telomerase. Nowadays, telomerase has become also very. You know how much is the ability? How many times cell can divide? And you said that each time when cell divides,
Yes.
this telomerase then generates.
So normally they have mentioned in the book 50 to 60
Yes,
times.
50. So anyway, now there is less time to discuss about the lot of stuff. Again, any comment of the one?
आप सारे हॉलमार्क के 2 क्लिनिकल एग्जांपल्स बता दो. सबसे पहली साइकिल में चले जाओ जिसमें ये सारे हॉलमार्क हैं. एक पकड़ लो, स्लाइड कर ले, पेन स्लाइड भी.
आप लास्ट वाली स्लाइड से बता दो. लास्ट स्लाइड है ना.
सारे एक पेज पे 2 क्लिनिकल एग्जांपल.
Clinical example is की.
ऑन्कोजेनेसिस में कुछ हमें समझना है या थेरेप्यूटिक इम्प्लीकेशन, डायग्नोस्टिक इम्प्लीकेशन.
फॉर एग्जांपल जैसे मैं आपको और क्लियर कर दूं, जैसे ये ट्रीटिंग केस क्रॉनिक माइग्रेन कौन सा उसमें और बात है जो कि
Leukemia नहीं
We are worried about the regular malignant, so they have given the what type of drug we are using and to control the cell.
मेरे पास हो गया सस्टेनिंग
Proliferative signal.
तो उसमें आपने कौन से मॉलिक्यूलर मार्कर का एग्जांपल दिया था
Ras and
इसको छोड़ दो बता दो
proliferative signals में मैंने डाउनस्ट्रीम पाथवे मेंशन किए थे, oncogenes मेंशन किए थे, growth factors मेंशन किए थे. इसमें एपिडर्मल ग्रोथ फैक्टर जिसके लिए हम ड्रग भी यूज करते हैं, जेप्टिनिब, एपिडर्मल ग्रोथ फैक्टर्स और हर HER रिसेप्टर्स, ह्यूमन एपिडर्मल ग्रोथ फैक्टर्स. EGFR में we are doing in the head and neck also for EGFR. Lung, to the breast.
फिर उसके बाद इवेडिंग कौन सा प्रेशर इसमें क्या बताया था
इसमें ट्यूमर सप्रेसर जीन्स का था, रिटर्नोप्लास्टमा और DP53 के बारे में था.
रेटिना प्लास्टिक आरबी
जी.
फिर उसके बाद 353 तो कॉन्सेंट्रेट
Most of the cancers are associated with P53. Familial syndromes are the Lee-Fermany syndrome. उसमें
अवॉइडिंग इम्यून डिस्ट्रक्शन इसके दो एग्जांपल बता दो
इसमें we have the checkpoint inhibitors, CTLA or PDL1 immune checkpoint inhibitors थे.
फिर इनेबलिंग रेप्लिकेटिव इमोर्टैलिटी टीलोमेरेज
हाँ जी,
इसका
टीलोमेरेज.
एग्जांपल बता दो
इसका
इसकी कोई क्लिनिकल ड्रग नहीं है अभी तक तुम्हारी
एक
नॉलेज
ट्रायल में इन्होंने मेंशन किया होता है बस, निटिप करके एंड में निटिप करके कुछ ऐसा है, वो ट्रायल्स में है पर ऐसा नहीं आया.
कॉन्सिक्वेंसेस में उन्होंने कहा जहाँ पे पोल्यूशन ज़्यादा हो रहा है वहाँ पे चेक किए और वो टोटल बता So I think we can also say that Delhi में कितने telomerase है और North में कितने telomerase है they will problem. तो इसके बाद
Promoting inflammation, इसमें उन्होंने एंटी इन्फ्लेमेटरी ड्रग्स के मेंशन किया हुआ है, एस्पिरिन और सेलोकॉक्सिब. Yes, will reduce the inflammation. हाँ जी, हाँ जी.
क्या
So COX-2 inhibitor, selective COX-2 inhibitor, so reduce the inflammation.
आपको पता है और एस्पिरिन किस कैंसर में यूजफुल है
एस्पिरिन का कोलन कैंसर में था प्रिवेंशन, पर अभी आई थिंक अभी कोई पेपर आया उसमें वो कह रहे हैं कि इट्स एक्चुअली कॉजिंग लॉन्ग टर्म प्रोलॉन्ग यूजेज ऑफ, मेरे को पता नहीं है तो मैंने जस्ट देखा था, प्रूव नहीं आया अभी.
मतलब ये होता है कि आपके डायबिटीज वो डेली डायबिटीज हाइपरटेंशन डेली नुकसान है
हाँ जी.
फिर एक्टिवेटिंग इन्वेजन मेटास्टेसिस
जी. इसमें भी सो इन्वेजन मेटास्टेसिस में कैस्केड बताया था, अगेन द सीड एंड सॉइल थ्योरी एंड मेटास्टेसिस. सीड एंड सॉइल थ्योरी थी.
तो आपको ये पाथवे नहीं था इसके अंदर ईएमटी था ना
हाँ, EMT पाथवे था और EMT एपिटल मेसेंकाइमल ट्रांजिशन.
practicing vasculature
Anti-VEGF therapies, bevacizumab और जो ड्रग्स क्लास ऑफ थी,
और
एंटी-VEGF था और एक एंटी ड्रग्स.
नहीं आप किडनी में क्या लेते हो
किडनी में
सिनेटर वगैरह ये सब
ओके. हाँ जी.
फिर उसके बाद genomic instability and mutation इसमें क्या था?
इसमें था इसमेटिक म्यूटेशंस और एपिजेनेटिक अल्टरेशंस।
Epidemic के बारे में क्या करते हैं? Well, they are in clinical review.
Yes, ma'am.
फिर resisting cell death.
Yes, तो अगेन एंटी ड्रग्स हैं जो BCL उस पे एंटी एपोप्टोटिक पे काम करते हैं, उनका रेगुलेशन कम करते हैं।
BCL के पास मतलब clinical review पे
Very famous recently launched in India. Venetoclax protein?
जी,
Venetoclax.
sorry, I didn't study the drugs.
आपको पता है कि वो
हाँ जी, हाँ जी,
So now they are coming in clinical review due to the factors. फिर उसके बाद dysregulating cellular metabolism. और आपने देखा ना BCL2 और किसके इवैल्यूएशन में आएगा, मतलब अदर देन का कौन सी डिजीज के वर्कअप में देखना होता है
लिम्फोमास
क्या डिसाइड करते हैं उसको? कोई नॉन हॉटस्पॉट लिम्फोमा है उसमें आप कुछ IHC का सेट लगाते हो, उससे क्या डिस्टिंग्विश होता है?
थेरेपी
दो कौन सी कैटेगरी बनाई जाती है NHL की? NHL में DMPCL आ गया
क्लासिकल नॉन क्लासिकल नॉन हॉटस्किन लिम्फोमास
नॉन हॉटस्किन आया, उसके बाद में DMPCL आ गया, अब आगे से चाहिए
Hence the algorithm used the
सब कोरिलेशन में रहता है, मैं याद नहीं है आपको भी याद नहीं होती है क्लिनिकल प्रैक्टिस कॉम्प्लिकेशन। तो लास्ट पे हो गया सेलुलर मेटाबॉलिज्म।
इसमें वो वार्बर्ग इफेक्ट और एक्सप्लेन किया था।
इम्प्लीकेशन क्या है इसका? आपने बोला था GNDP रिसेप्टर्स ओवर एक्सप्रेस हो जाएंगे।
हाँ जी,
वेरी कॉमनली यू आर डूइंग दिस। क्या कर रहे हैं कॉमनली? अभी स्टेट बोर्ड से बात करते हैं, क्या करवाते हो आप?
पेट स्कैन।
क्यों करवाते हैं पेट स्कैन? मोस्ट कॉमनली डन पेट स्कैन है
टू चेक द
नहीं, मोस्ट कॉमनली आप एजेंट क्या यूज कर रहे हो?
फ्लोरोडीऑक्सी 18 फ्लोरोडीऑक्सी
क्या पढ़ना हुआ?
उसका भी सेम वार्बर्ग इफेक्ट और ग्लूकोज अपटेक पर।
और कोई एंजाइम है जिसके लिए तब दे रही है सेलुलर मेटाबॉलिज्म ग्लाइकोलिसिस के एंजाइम्स के लिए? ये सब मैथ भी कर रहे हैं हम लोग तो तीनों ही दे रहे हैं। ठीक है, और भी आप देख लो ना इसी वजह में भी है तभी हम पाएंगे कितना होगा 10 10 10
अगली बार 10 को स्कूल पहुंच के आप जगह देख के बता दो ठीक है ठीक है कर दो याद होना चाहिए
क्योंकि लॉन्ग आंसर है
and after the discussion don't feel bad of joining radiotherapy. You are saying medical body take a lot of theory. Don't try to change your mood that after radiotherapy. Many doctors are doing that nowadays. That they do and they radiotherapy and then I need to medical. Okay. But as he said, is very important.
Yes, sir.
That for each hallmark, we should know the practical application. That when we are out of this hallmark, what are the important implication of that particular thing as overexpression, hyperexpression, whatever. And then what else we do. So then it completes your knowledge of that.
So one small, very small suggestion, when make the presentation, whole idea is to deliver the message. Not to tell exact pathway is there. You start telling pathways will be too much. So how do you make not more than 4 bullet points per slide? Do not put any slide which you cannot even read. So a lot of journey in one's life needs this person. So next time you put minimum and more also was important. Minimum.
Okay. Very good said.